Um, Assalamu alaikum everyone. I hope you're all doing well, inshallah. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fifth year medical student, and inshallah, today I'll be giving you guys a two-part crash course this time. Inshallah, it will be the HNS crash course. This session will be on ENT, so ear, nose, and throat, inshallah. And then tomorrow I'll be covering ophthalmology. Now, the way my session is similar to my MSI crash course that I gave you guys last semester. It will be very interactive. I expect you guys to answer me in the chat when I ask questions, and then I'll explain certain topics. Now, if you guys have any questions, ask it in the chat at any time, and I'll answer, inshallah. So what I'll be covering today, and in both this session and inshallah tomorrow, is the basic anatomy. I'll cover some points of it, not everything, because it's a lot of information. I'll cover whatever is clinically important in anatomy, and what I find clinically important. I'll cover all of pathology in this session. I'll cover all of the clinical ENT, which is the 4 lectures. I'll cover both radiology, the micro lectures associated with ENT, and then that's about it, inshallah, for this session. So without further ado, let's start with the face and skull. The first thing I'll talk about is starting from superficial to deep, inshallah, and from up to down, is scalp. So scalp, we have 5 layers. The skin, the connective dense tissue, which has a lot of blood supply and blood vessels. The aponeurotic layer, which is basically what will hold the occipitofrontalis muscle. Then we have the loose connective tissue and the pericranium. Now, what's very important about these layers is you need to know the associated pathologies with each layer, okay? So this has a lot of what inside of it. Similar to any skin in the body, you have glands and so on. So if you have, for example, sebaceous gland cyst or infected sebaceous gland, it will be in this layer, simple. Then we come to superficial scalp lacerations. Which layer from these 5 will be affected? Superficial scalp lacerations. Dense connective tissue, which will be a lot of blood supply, a lot of vascularity. So will this wound or laceration gape or not gape?
Not gape.
Mumtaz, good. So it will not gape. Which of these lacerations or which layer will gape if you have a laceration? Below the aponeurosis or the loose connective tissue. If you have a deep scalp laceration, it affects the loose connective tissue. The aponeurosis is what keeps the 2 muscles in place. If you cut this, it will just separate. So the wound will gape, okay? Then we have the pericranium. Below the pericranium, let's just say if you have a collection of blood below the pericranium and on the skull, what do we call this? Cephalohematoma, which is this. Now, when does this happen? This happens during delivery usually. So during delivery, it might be a complicated delivery. So we might use certain techniques to help deliver the baby, such as suction technique. You'll learn this inshallah partly in repro and in OB-GYN in 4th year. But basically we use a suction technique, and this could be a complication of that. Okay. So it's a collection of blood between the pericranium and the skull. Okay. So that is cephalohematoma. Now going on to the skull, I won't be going into too much detail with the skull, okay, because there's too much. But it's divided into 2. We have the neurocranium and the visceral cranium, okay? Now the important thing about the skull are certain bones. Now over here is a petrion, which is basically the connection of 4 of the cranial bones. What artery lies right below it?
Middle meningeal.
Mumtaz. Good. So middle meningeal. What's important about this, if you have trauma to this area, it will lead to rupture or damage to the middle meningeal artery, and then that would lead to a hematoma, which we'll get to which one. And you guys already took this in your asl. Then we go to this bone. What is this bone over here? Temporal bone. Temporal bone has multiple parts to it, okay? And as you can see, you have the squamous part of it, the mastoid part, then you have the zygomatic part of it. Then you have one which is very important, which is inside a bit, which is the petrous part of the temporal bone. What's important about the petrous part of the temporal bone is it has a specific canal, which has two nerves in it, and we'll get to it inshallah in a bit. Now, when you suspect any cranial pathology, whether it's a fracture of the skull, whether you want to observe suture lines, whether whatever, you do an image. Okay, so this is a simple X-ray, and you can see some of the suture lines. Now, the sutures will connect two skull bones together. What's important about this is during development of a baby, the sutures help the bones grow in certain directions. Okay, so you have the two coronal sutures, and then one sagittal suture, and then two lambdoid sutures. The sagittal sutures will allow the bone or the skull to grow laterally. The coronal and lambdoid will grow it anterior-posteriorly. Okay, so this direction. The sagittal will allow it to grow laterally. Why is this important? This is important is if you have an abnormal or premature closure of one of these sutures, the skull will deform. Okay, it will grow in one direction, but not in the other direction. And we'll get to these examples later on, inshallah. So now what's very high yield, and you already took some of this or majority of this in neuro, is the skull-based anatomy. You need to know where the cranial nerves come out from. Important arteries, it's usually nerves and arteries that you need to know. Veins are less important. But the skull base, we divide into three sections. We have the anterior cranial fossa, middle cranial fossa, and then the posterior cranial fossa. So the anterior cranial fossa will have the frontal bone, and then you have the ethmoidal bone. Now this ethmoidal part is going to be the cribriform plate. Which nerve comes out of the cribriform plate?
Olfactory.
Olfactory nerve, good. What arteries? Think of it.
Ethmoidal artery.
Ethmoidal, good. The anterior posterior ethmoidal will come from it, okay? What's important is anatomy in terms of which artery will give off the anterior and posterior ethmoidal arteries. It's a branch of what?
Maxillary.
No, the one above. Ophthalmic, good. So it's a branch of the ophthalmic artery. So the internal carotid, when it goes inside the skull, it will give off one branch, which is the ophthalmic artery. The ophthalmic artery will give off the anterior and posterior ethmoidal arteries, which will go through the cribriform plate and then will form a plexus in the nasal cavity, okay? Which we'll get to inshallah. But what's important is this part over here of the bone, if it gets, for example, if you have a trauma, a fracture, this is easily going to cause a CSF leak, okay? And will affect the what's it called, olfactory nerves, olfactory bulb, and then the nerves. So you'll have lack of smell. What do we call lack of smell? Anosmia, good, perfect. Then we go to the middle cranial fossa. Over here you have a canal. This canal is the optic canal. From the name, what nerve is in the optic canal? Optic nerve. What's the blood supply of the eye? Ophthalmic artery. So you'll have the ophthalmic nerve and the ophthalmic artery going into the optic canal to supply the orbit. Okay, optic canal obviously is for vision, and then you'll have the ophthalmic artery, which supplies most of the orbit in terms of the structures of the orbit. Then we go over here to the superior wing, the greater wing of the sphenoid, which will have multiple canals. So number one is the superior orbital fissure. The superior orbital fissure will have a lot of nerves. Ones I want you to remember is firstly V1. Okay, so what's V1? What nerve is V1?
Ophthalmic.
Ophthalmic, which is from the trigeminal. Good. So this one will go through the superior orbital fissure, and all the nerves that supply the extraocular muscles for movement will go through the superior orbital fissure. Tamam. Then we go to this one, which is ovale, which will have the mandibular nerve. Then we go down here. Now, over here, you have one canal, which is going to be for the carotid. Okay. Now, this canal will have the carotid plus the sympathetic plexus that's coming from the neck. Okay. Then we have the foramen spinosum, which will have the middle meningeal artery. Now, middle artery will run behind the petrion, which is a combination of the four bones. So that's what you took in neuro. Coming over here this is the temporal bone, and this is the petrous part of the temporal bone. I said we have a canal here. This canal is the internal acoustic meatus, which will go to the inner ear. Okay. So in this canal or meatus, you have two important nerves. What are these nerves?
Facial and vestibulocochlear.
Facial and vestibulocochlear. Good. Tamam. Facial, vestibulocochlear. So facial will supply the muscles of facial movement. Vestibulocochlear will have two components, the hearing component and the vestibular component for balance. We'll get to all of that function later. Then we have some other ones, such as the jugular foramen, which will have glossopharyngeal, vagus, the accessory, then the hypoglossal, which will have the hypoglossal. Tamam. Now, what's important is you recognize these features. So now, you have this patient who had a motor vehicle accident coming to you with these features. What is the finding that you see on this image, this middle one? Bell's palsy, or go a bit broader.
Paralysis of facial nerve.
Facial nerve paralysis, facial nerve palsy. Good. Now, how can you tell this is a lower motor neuron versus upper? Which movement will you ask them to do? Raise the eyebrows. If they're able to raise the eyebrows, this is a lower or upper? If they're able to raise it, this is upper. Good. If they're not able, this is lower. In this case, you ask them, he's raising this side, which is the left side. So this is normal, this side of the face. But here, nothing's moving. So this lesion is on the right side of the face, and it's a lower motor neuron lesion. So this is Bell's palsy, or any form of lower motor neuron facial nerve palsy. Okay. Now, he also tells you that he can't hear from his right ear. So where is this lesion? And if you do imaging of the skull base,
Temporal.
exactly, the petrous temporal bone. Okay, so this is a temporal bone fracture. What's important for you to remember is the association of the temporal bone, specifically the petrous temporal bone, with the facial nerve and the vestibulocochlear nerve. It has both of these nerves. So any fracture of the temporal bone involving this will have these two nerve pulses. Okay, so that's good. Then we go to this one, which is super high yield for you guys. Motor vehicle accident, and this is what you see on emergency. What is this diagnosis first?
Raccoon eye.
Good. This finding is raccoon eye. Good. What do you see here?
Base cell.
Fracture. Yes. So fracture of the anterior cranial fossa. Good. So if you ask the patient to bend their head forward, okay, you'll see clear fluid going down from one of the nerves. Clear fluid, and it's dripping one by one. And then you put the tissue paper, you see this finding. What is this? Halo sign, which indicates what? CSF rhinorrhea. Okay, so CSF leak. Rhinorrhea is nasal discharge. Okay. CSF rhinorrhea is when there's CSF dripping from the nose. Okay, due to many reasons. The most common cause of CSF rhinorrhea, and I want you guys to remember this reason, is iatrogenic, surgical. Okay, so surgeons, when they're doing any rhinoplasty procedure, turbinate procedure of the nose, they might damage this part over here, which is the cribriform plate or the ethmoid. If we damage here, CSF can leak out. Tamam? And when CSF leaks out, it can cause infection or anything to spread out. Now, in the context of this patient, which is a motor vehicle accident, this is an emergency. So we treat them surgically, immediately sent to OR and fix. But in cases of, if we did it, and surgeons iatrogenically, then we just tell the patient to wait, okay? Now, to diagnose patients with CSF rhinorrhea, like this one, we do physical exam, which will show us this sign. This is called a halo sign. This is an important thing for your exam, okay? CSF rhinorrhea, halo sign. Once you see this in the question, you know what's the issue. Now, this is not the most specific thing. You do imaging and you can see clear communication between the nasal cavity and the cranial fossa. Tamam. This test over here, I want you guys just to name me what this test is. This is the most specific test to diagnose patients with CSF rhinorrhea. What is this test? Okay. This test is called beta-2 transferrin test. Okay. This is a very specific substance that's located inside the CSF, and it's only in the CSF. There's no way that any nasal discharge will produce beta-2 transferrin. Okay. So what we do is we collect it and we send it for analysis. If there's high amounts of beta-2 transferrin, this tells us that there's CSF leak. Okay. What I want you to remember is in anterior cranial fossa fracture, you have a high propensity of developing CSF rhinorrhea. Okay. And it's very dangerous. And then you have other signs of CSF, of anterior cranial fossa, which is this, which is raccoon eyes. Okay. Tema, what is this? It should be very fast. You took this in neuro and you probably were examined in neuro. Epidural hematoma. Good. I'm not going to go into details of this because you 100% took this in neuro. Okay. How about here? Here, there's multiple things going on. So here, you have multiple fractures going on, probably a motor vehicle accident or something. But I just want you to recognize that we use CT scans, in this case, a non-contrast CT, to diagnose patients with trauma. Okay. It's a modality of choice, and I want you to remember that. So over here, you have a small epidural hematoma. Over here, you have a small subdural hematoma. Here, some hemorrhage or edema is happening. And then there's a lot of blood in the sulci of the brain, which indicates a subarachnoid hemorrhage. So there's multiple things happening with this patient. So there's multiple hemorrhages. This is usually a trauma case. Okay. Now we're going to go elements of pathology, not pathology, of radiology, which I really do not know why you guys are learning certain things here, but it's part of the course and lectures. This is less important for you to remember, but I'll explain the concept. So in this case over here, you see multiple osteolytic lesions, and I explained somewhat in MSI what that is. But basically is if you have high metabolic activity in the skull that causes these punched out lesions that develop in the skull, okay? There's multiple things that can cause this. I don't want you guys to remember them, but I just want you to identify that these are osteolytic lesions, okay? This could be malignancy. This could be, for example, hyperparathyroidism. This could be so many other things, okay? You'll learn somewhat of what can cause osteolytic lesions as you go through third year, inshallah. Then we have this, which is kind of important. Can you guys tell me what this diagnosis is? Just by looking, you have a very large mandible, huge sella turcica.
Acromegaly.
Acromegaly, mumtaz. So this is acromegaly, which is caused by a growth hormone secreting pituitary adenoma. Okay, pituitary gland secretes hormones. What are these hormones? Growth hormone. Growth hormone very high, especially in adults, will cause acromegaly. Okay, acromegaly is when a lot of the bones that's not supposed to be growing will grow larger. So the frontal bone will start to protrude outwards, causing this thing right here, which we call frontal bossing. The mandible will grow huge. As you can see, this mandible is huge and it's protruding outwards. Then you can see the sella turcica itself. It's much bigger than normal. Then you can look at the skull. The skull looks a lot thicker than it should. It's a lot more opaque because it's thickened. So that is acromegaly. So this you will learn in detail in HEMONC, inshallah, next semester. But basically, this is a hair appearance that we see on thalassaemic patients, okay? Just to explain to you why this happens, again, this is very low yield for you to remember, but basically in thalassemia patients, their bone marrow is not being able to produce enough. So it just starts to produce blood cells everywhere. So once it produces blood cells, one of the areas that it will start producing blood cells is a skull. So it grows like this and appears like this, appears like hair, okay? But this is all the skull growing. And it causes abnormal facial features in children with beta thalassemia. Okay. Then here you can see multiple things happening with this patient. What is this diagnosis? There's a cut over here.
Mandibular fracture.
Mumtaz. Good. So this is a mandibular fracture. Again, we use imaging just to diagnose it. I just want you to recognize if we see this type of fracture, this is called a hairline fracture, I think. And then you can see an element of a dislocation of the temporomandibular joint over here. Okay, so this is fracture, dislocation here, fracture here, okay, of the mandible. Do you need to know this? I doubt you will be asked this, but this is just for the sake of identification and completion, okay? Then this, again, it's very low yield and very advanced for your level to know what Lefort fractures are. Even me, who's doing ENT currently, it's not that asked, at all. But to explain it to you, is Lefort fractures are fractures that separates the teeth from the rest of the skull. And it's basically to classify facial fractures that happens in the maxillary bone and surrounding bones, okay? As this fracture extends beyond the maxillary bone, the degree or the severity is worse. That's the whole point of this, okay? So Lefort 1 is basically going to separate the teeth from the rest of the maxilla, and the fracture is only in part of the maxilla, which is bordered by the inferior part of the maxillary sinus and the teeth. That's it. So it's a very smaller fracture. This one extends much more, so it goes to the nasal frontal suture, which is this one over here, and then goes part of the maxillary sinuses, okay, and the lateral part of the maxillary sinus, and same thing over here. This is what we call a pyramidal fracture, okay? This one just goes beyond that. So you have nasofrontal suture, then you have the zygomatic frontal part, okay? So this is more severe, this is less severe, this is least severe. That's all I want you to remember, okay? Would you get asked about this if they decide to go very low yield? Yes. Okay, but just for you to know. Now to something actually you'll be asked about is skull sutures and fontanelles. So skull sutures, as I said, are the suture lines that will attach two bones together, and they basically allow for the bone to grow during development, okay, or the skull cavity to grow during development. So the coronal sutures, you have two. They allow for anterior posterior growth. Sagittal suture will allow for the lateral growth. Lambdoid, the same as coronal, but posteriorly, okay? Then we have the fontanelles. The fontanelles, the thing about them is you need to know when they close. So anterior fontanelles, when do they close? Okay, they grow, or they close 9 to 12 months. I need just a bit more interaction, guys. 9 to 12, or 9 to 18 months, sorry. Then the posterior is around 2 months. The thing about them is if this is not present, the posterior fontanelle, if it's not present, it's associated with hypothyroidism, just remember that. Anterior, it's going to be associated with suture defects, okay, or skull defects. Tamam? Now, if you have an abnormal closure of one of these suture lines that is premature closure, we have skull defects, which are called craniosynostosis, okay? So craniosynostosis is premature closure of the suture lines, which will cause multiple defects that happens. So number one is scaphocephaly. Scaphocephaly is closure of the suture. Which one is the suture?
Sagittal.
Sagittal. Sagittal will allow lateral growth. In this case, can lateral growth happen if there is a abnormal closure or premature closure? No. So how will it go? Anterior posteriorly. So babies with scaphocephaly or scaphoencephaly will grow anterior posterior. So you'll have a long shaped head. Okay. Plagiocephaly, I don't think you'll need to know. Brachycephaly is important. It's closure of the two coronal sutures. So in this case, anterior posterior growth won't happen as well. So you'll have lateral growth. Okay, so the head will be wide and narrow when it's anterior posteriorly. Tamam. Uh, oxycephaly is when you have closure of the two coronal and the two lambdoid sutures. Okay. Here, you just need to recognize which sutures are closed and the associated defect. And this you will get asked in your exam in anatomy. Okay. Tamam. Now, something very high yield, the facial nerve. Okay. So with the facial nerve, I want you to remember some of these branches. Okay. And I want you to remember the course very well. Much more, trigeminal is important anatomy and to identify it in OSPE. But facial nerve is important in a lot of MCQs. It's very commonly asked and clinical. It's very important for all of these. So you will get asked about the course of the facial nerve 100%. So the facial nerve, it will come from which part of the brainstem?
Pons.
Pons, good. So then it will go through the skull, okay, through the middle cranial fossa, and enter here. Through the petrous part of the temporal bone, it will go into, or sorry, in the posterior cranial fossa, it will enter through here. Here is the internal acoustic meatus with vestibular cochlear nerve. Then it will go to this ganglion, which is the geniculate ganglion. It will give this branch, which is the greater petrosal nerve, which does what?
Parasympathetic.
Yes, to
Delivery.
what?
The salivary glands.
Good.
Submandibular.
Not submandibular. It's the palatine. Submandibular is a bit later. But good job. It's parasympathetic to lacrimal. I want you to remember, very importantly, is lacrimal gland. Okay, good. Then it will go through the facial canal. Okay, and it will give off one important branch, which is the nerve to stapedius. تمام. This is important for dampening of the noise. Okay, then through the facial canal, it will then give off this important branch, which is the chorda tympani. The chorda tympani will supply what exactly? And what sensation does it carry? Taste to the anterior two-thirds of the tongue. Good. What nerve does it join to go to anterior two-thirds of the tongue? Lingual nerve. Mumtaz. Which is a branch of what nerve?
Trigeminal.
Trigeminal, and more specifically, mandibular. تمام. Mandibular nerve. تمام. So it will go with the to that through with the lingual, okay? To the anterior two-thirds of the tongue. Lingual is sensory, okay, of the anterior two-thirds. General sensations. The chorda tympani, which will join with the lingual, will carry the taste sensations. تمام. Then it will leave the cranial cavity through the stylomastoid foramen. It will give off sensory branch, which is posterior auricular nerve, very small branch. And then it will give off the 5-terminal branch. Which substance or which organ does it give off the 5 branches? Through the parotid gland. Good. So in the parotid gland, it will give its 5 terminal branches, which are temporal, zygomatic, buccal, marginal mandibular, and cervical branch. 5 branches, which supply the muscles of facial movement. Why is this important? Is you need to identify the level of the lesion in the facial nerve. You need to know exactly where the lesion is. So if I tell you, if someone had a parotid gland tumor and we removed the parotid gland and we forgot, oh, the facial nerve was inside there and we forgot, will the patient be able to move the muscles of the same side of the facial muscles?
No.
No. Will they have difficulty tasting?
No.
No. Good. They won't have difficulty tasting because that branch is over here, not in the parotid gland. Okay. It gives it off at the facial canal in the middle ear. So they won't have difficulty tasting. Will they have difficulty with lacrimation?
No.
No. Good. Will they have any hearing difficulty or loud noises, hyperacusis? No, good. Let's just say if it's at the facial canal over here, at the second genu of the facial nerve. Will they have difficulty moving their facial muscles? Yes. Will they have difficulty tasting?
Yes.
Yes, but everything else is normal. If it's at the internal acoustic meatus or at the level of the pons, right outside of the pons, such as the cerebellopontine angle, let's just say there's a huge meningioma or something there, then yes, everything will be damaged. This is what's important about it. Okay. Now, something else I want you to remember is any surgery to the middle ear or the mastoid, which is this bone over here, or this part of the bone over here, or the parotid gland will affect the facial nerve. So you need to be very careful. That's what's significant about it. Until now, is everything clear? It's very anatomy dense in the beginning, then we'll go rapidly through everything else. Then the muscles of facial expression. You have a lot of them. There's not much that you need to remember in terms of this. You just need to know what does the facial nerve innervate and the muscle movements, the main muscles of certain things. So over here, you have the frontalis muscle, which is part of the occipitofrontalis muscle. What is the main function of this?
Raising the eyebrows.
Yeah, raising the eyebrows. Good. What is this muscle? Orbicularis oculi. What's the main function?
Opening and closing the eyes forcefully.
Mostly closing the eye. Okay. Mostly closing. Then you have, for example, the buccinator muscle, which will help to open the mouth with also this one and the side-to-side movements. Then you have this, which is the orbicularis oris, okay? And then you have, for example, this big muscle over here in the neck, which is the platysma muscle. These are some of the muscles that you need to remember. So over here, we already diagnosed and we already know how to identify the lesion. In this case, what is this lesion? Can move the front eyebrows over here, can move it up, but can't on this side. So what lesion is this?
Bell's palsy.
Bell's palsy. Which side?
Left side.
Left side. Good. Left. Okay. Flip it. And it's your right side. My right hand is on that side of the lesion, but you just flip it. So it's left side. Good. Now, Bell's palsy, just a few things for you to remember is usually the case is idiopathic. The phenomena that we think is it's facial nerve edema because of viral infections. There's one important viral cause of Bell's palsy. Do you know what or of facial nerve palsy? Do you know what that virus is? Other than mumps, but I see why you're thinking mumps, but other than mumps, which doesn't directly. Let's just say, I'll tell you it's HSV, okay? Herpes simplex virus. If you have herpes simplex virus with Bell's palsy, this is what we call Ramsay-Hunt syndrome, okay? Why this is important is when we treat them. If they have herpes zoster affecting one area of the trigeminal, let's just say, plus facial nerve paralysis, then we treat them with steroids plus antiviral. That's what's important about it. That's usually the case is idiopathic, and when it's idiopathic, we don't know the cause, we call it Bell's palsy, okay? Management is simple in this case, is just give this patient steroids. Now the trigeminal nerve. I won't go into details with it because it's a lot, but you have three main branches, ophthalmic, the maxillary, and the mandibular. The ophthalmic will go to the eye and supply most of the eye sensory innervation, okay, and for the forehead. And then you have parts that will go into the nasal cavity, which is through the nasociliary, not the nasociliary from here. But anyways, you have the, no, nasociliary branch, okay, from the ophthalmic. Then you have the maxillary, which will go to the pterygopalatine fossa, and then will give off many branches, such as the greater palatine and whatnot. And then you'll have over here, which is the mandibular, which will give off the lingual branch and so on. Okay. Now, each of these nerves will leave the skull through different foramens, such as the supraorbital, infraorbital, and the mental foramen. Okay. So that's trigeminal nutshell, you need to go into more details in terms of what these supply, okay? Now, the branch, which is V3, which is the mandibular, will have motor function, which is to the muscles of mastication. Now, from the muscles of mastication, we have four. We have the masseter, the temporalis, medial, and lateral pterygoid. Masseter is this one over here. You can feel it if you chew, okay? Temporalis is here, and then the two pterygoids are a little bit deeper. What I want you to remember is there's one muscle that will help depressing the jaw. Which muscle is that? Lateral pterygoid, good. It's the one muscle from these four muscles. There's obviously accessory muscles that will help it, but from these four muscles, it is the only muscle that will depress the mandible, okay? This is important, very important and high yield. Another thing is if you have a dislocation of the jaw, which direction does it usually dislocate?
Anteriorly.
Anteriorly, and more specifically, anterior inferiorly. Excellent. Good. And one other thing is if you have a patient who's complaining to you that they have a lot of ear pain when they chew, and they have a lot of pain over here in this area, this lesion, this region, and a lot of ear pain, and specifically when they chew a lot. What do we call this disorder? It's from the name. What is this joint? TMJ. So this is called TMJ syndrome or disorder, okay? And it's usually because of repetitive chewing or muscle fatigue here, or if you have, for example, someone who grinds their teeth at night, okay, they can develop it, okay? So that's basically what you need to know from the muscles mastication. That's high yield, and the disorders of the TMJ and the mastication.
Do we have
Now,
to memorize the origin and insertion?
usually, I'm not sure. It's not always asked, but you should. And some of these you can kind of guess by any method. And here is a temporalis. You have the temporal bone and then inserts into the part of the mandible, the cricoid, the coronoid process. Then you have the masseter, zygomatic arch, all the way to the lateral surface of the rami, which is this part of the mandible. Then the two, which is inside. I think the pterygoids, you need to know it, especially for urology.
Okay, thank you.
No problem. So now the artery supply of the face, we have which carotid? Is it internal or external that supplies it?
External.
External, good. Let's go a bit into the external carotid artery. Now, the external carotid artery will give off multiple branches. The main branches to the face is the facial artery, the maxillary artery, and the superficial temporal artery. Superficial temporal artery gives off what artery? Important that goes into the skull. I think, if I remember correctly. Middle meningeal. So anyways, going back to here. The external carotid will give us multiple branches. You have, for example, the posterior auricular, the occipital branch, the superficial or the superior thyroid. There's one more, which is the pharyngeal branch. And then you'll have the facial branch over here, which is a very vascular one. Then you have the maxillary, and then you have over here the superficial temporal artery. Okay. What do you need to know it is it's very hypervascular. Traumas to these area will cause severe bleeds. Okay. Now, what's also very important is this facial artery will give off the superior labial artery, which will go into the nose and supply the nasal septum. Okay, that's pretty much that. What's more important for you clinically is the venous drainage. Why is that so? Is its communication with the cavernous sinus. Okay, so from the facial vein, or let's just say ophthalmic vein, superficial or the superior ophthalmic vein can go directly to the cavernous sinus. Facial vein will go to the pterygoid plexus or the inferior ophthalmic into the cavernous sinus. Okay. Why is this important? Is if you have to this area of the face, which is a danger triangle of the face. So for example, sinusitis, cellulitis, anything in this area or superficial or, for example, dental infection, can go into the cavernous sinus and cause cavernous sinus thrombosis. What's important about cavernous sinus thrombosis is the structures inside the cavernous sinus. So you'll have the abducens nerve palsy, you'll have the oculomotor, you'll have some sort of ophthalmoplegia. And another thing is the cavernous sinus is important of the venous drainage of the brain, okay, of the cranial cavity. So you'll have increased intracranial pressure, okay? So patients will be very sick, will vomit, will have a severe headache, will have difficulty moving their eye. Okay, that's a few clues. And then if you are able to take history from this patient, they'll tell you, oh, I had some sort of sinus infection or rhinitis or whatever 2 weeks ago that wasn't treated properly or something. Okay, so that's just something about the venous drainage. Now we'll go into pathologies and some of the disorders of the salivary glands. So you have multiple salivary glands bilaterally. You'll have the parotid, which is the biggest one. Then you'll have the sublingual and submandibular. Easy. Here it's a mixture of mucinous and acinous glands. Okay, not a lot you need to remember here. Then the parotid region. The parotid region is superficial. It's bordered, its borders anteriorly is the buccinator muscle over here, zygomatic arch superiorly. Then you'll have the external ear, okay? Then you have the, what's it called, sternocleidomastoid, and over here is the angle of the mandible, tamam? These are the borders of the parotid gland. Then we have the parotid duct, which you need to know its course. It will pierce which muscle does it pierce?
Masseter.
Not the muscle.
Buccinator?
Buccinator. And so I said this is buccinator, this is not, this is the masseter muscle. So it runs on the masseter muscle, pierces the buccinator muscle, and it will go open on the ostia, which is next to or in front of the second molar. Okay. Usually they love to ask about the parotid duct pathway. Okay, so for you to remember. Tamam. So this is the parotid gland. Now, the important thing about the parotid gland itself is it has the facial nerve. That's number one important thing. Now, what supplies the parotid gland? What is the parasympathetic supply, if I want to ask more specifically? Which nerve?
Glossopharyngeal?
Glossopharyngeal. It goes, the glossopharyngeal, the postganglionic fibers is through the auriculotemporal nerve. Good. Someone said in chat. Auriculotemporal, but the parasympathetic supply is from the glossopharyngeal. Postganglionic fibers, it goes with the auriculotemporal. And more specifically, accent is a lesser petrosal nerve, Mumtaz. So it goes into the parotid gland. Let's just say this patient had a parotid gland surgery, okay? A few months after the surgery, they tell you that every time I eat, I start to sweat in this area of the face. I start to sweat here and it turns very red. What is this syndrome called? Frey syndrome. Excellent. What is the cause of Frey syndrome? Is if you have the auriculotemporal nerve and the sympathetic fibers, because of abnormal healing, they start to connect together, and this will cause this effect, which is every time they eat, they have this area of redness and sweating in this area. Okay. This is called Frey syndrome, and it's because of the auriculotemporal nerve with the sympathetic fibers. Okay, tamam. This is the parotid gland again. I explained the important structures inside. What you really need to know is the facial nerve, the fact that the facial nerve is inside the parotid gland. This is usually commonly asked. Other than that is you have the carotid, okay, and the jugular. Tamam. Now, for salivary glands pathology, and this could affect any salivary gland, I want you to remember this type of algorithm, and I'll explain some terms. Is firstly, if I say sialolithiasis, this means that there's a stone obstructing the duct of the gland. So this is a common theme. If you have a stone, we call it lithiasis. So sialo is for the gland, salivary glands, sialolithiasis. Duct or stone obstructing the duct of the gland, okay? Now, what's the gland gonna do is it's gonna secrete saliva, okay? Let's just say. The saliva needs to get out of the gland, into the duct, and into whatever cavity it goes into, okay? So now, if you have obstruction of this duct, where is the fluid gonna go? Nowhere. It's gonna stay inside that gland. So the gland will start to increase in size and start to inflame. This is called sialolithiasis. If there's something, a stone, obstructing that duct. If it causes inflammation of the duct, this is what we call, or in the gland, sorry, this is what we call sialidinitis, okay, which is inflammation of the salivary gland. Tamam. This one, if the stone gets lodged out for any reason, it goes down in size. Okay, so that's how you can tell sialothiasis. Tamam. That's why it increases with eating, is because you salivate more with eating. Then we have constant, is because of the inflammation. Okay, simple. Usually it's viral, but you also have the suppurative or the bacterial causes as well. Then chronic swelling, which is long-term. We have bilaterally autoimmune, and we'll get to what the autoimmune causes. And then if it's unilateral, depends. Either it's tumor or chronic inflammation. Tamam. So now the most common cause of sialidinitis, which is inflammation of the gland, is this. What is this diagnosis? We should go a bit faster with these because it's clear just identification. It is sialidinitis, but what is the cause of the sialidinitis in this case? What is this? Not mumps. Mumps will cause viral sialidinitis and usually of the parotid. Here it's very small glands. This is mucocele. Okay, this is the most common cause of sialidinitis. I want you to remember this is the most common cause. Okay, is mucocele. It's this abnormal swelling, commonly of the lips. Okay, and you can see this is the whole cyst, basically, if you want to call it. Okay, filled with mucus. This part over here. This is mucocele, which is the most common cause of sialidinitis. I want you to remember that bit over there. Okay. Then to this. This is enlargement of the parotid gland on the left side. What is the most common viral cause of this finding? Mumps. Excellent. Now, mumps is a myxovirus, and I want you to remember, I think so, if I remember correctly. I want you to remember the complications of mumps. So mumps can cause parotitis, which is inflammation of the parotid gland, and can infect also two other important organs. Number one, which is excellent, is orchitis, which is inflammation of the testes. Okay, so it can cause infertility. The other organ is pancreas, so it can cause pancreatitis. Okay, so mumps can cause orchitis, pancreatitis, and parotitis. So the significance of mumps causing infections is decreasing over time because of the vaccine, MMR vaccine. Now, how about here? You have this patient complaining to you that every time they eat, they've noticed this large swelling below the mandible, and it increases in size when they eat, and then it shrinks after they finish eating. What is this? Go one step back. Could be bacterial, but what's this? Sialithiasis, stone. Tamam. How do I say this is stone? Is it's calcified or a lot of calcium, it's blue. Tamam. This is sialithiasis. This sialithiasis will cause bacterial infection. Why? Is because the fluids will stay in the gland. So it will slowly cause inflammation. This is acute inflammation. This is more chronic. Okay. So what is the most common cause of bacterial sialidinitis? What's the organism? Staph aureus. What's another one?
Pyogenes.
Not pyogenes. Similar to it, a bit. Viridans, which is all in the oral cavity. Okay. So viridans. Good. This is acute because you can see neutrophils over here in these multilobular cells. And then here is chronic, as you can see some fibrosis occurring. So this is bacterial sialidinitis. Good. Now over here, you have a patient complaining to you of dry eyes, dry mouth. What's the diagnosis?
Sjögren syndrome.
Sjogren syndrome. Excellent. Good. So if you remember from MSI, it's one of the autoimmune diseases causing keratoconjunctivitis, which is this, or dry eyes, Sika syndrome. And then you have xerostomia, which is dry mouth. Okay. So in this case, it's a autoimmune disease. How do you diagnose autoimmune conditions? What do you ask for in the lab?
ANA.
Okay. So you do antibody testing. Good. So the first thing is ANA, which is highly sensitive, but not specific. So in any autoimmune disease, most autoimmune diseases, not any, most of them, ANA will be positive, which will tell you, oh, this patient has some sort of autoimmune disease. Then you go into the specific antibodies. So for Sjogren, you guys said it very well. You have SSA rho and then SSB La antibodies. Tamam? These are very important antibodies. Now, over here on histology, you can see lymphocytic infiltrate. But these lymphocytes, this one over here, these are all the lymphocytes. This one's starting to change and show neoplastic changes. What neoplasm can develop from Sjogren syndrome thyroid gland diseases? B-cell lymphoma. ممتاز. Good. So B-cell lymphoma could be one specific complication of Sjogren. This is high yield. Okay. So Sjogren syndrome. Now we go to the tumors. This is a very most common benign tumor. This one. What is this? There's two tumors of salivary glands. I want you to remember this is one. Pleomorphic adenoma. Good. So this is usually at the angle of the mandible or mandibular mass. It's very well circumcised, rubbery mass, as you can see. And you can see multiple elements in this stroma. Okay, it's multiple cells. That's why we call it pleomorphic. You have epithelial and myoepithelial in the myxoid stroma. Good. Tamam. This is pleomorphic adenoma. It's the most common cause of, or the most common benign salivary gland tumor. Okay. Now, this one is more malignant. Now, what symptom or sign will a patient with a salivary gland parotid tumor come with that will tell you this is a malignant tumor? What sign or symptom? Facial palsy. Excellent. So if the patient has facial nerve involvement, this is a very high indicator that it is a malignant parotid gland tumor. And I say parotid a lot is because it's the biggest gland, it's the most common area. This is the most common malignant tumor, which is what? Mucoepidermoid carcinoma. Good. Again, what's high yield is facial nerve involvement. Another thing is important for pleomorphic is it usually extends past the capsule. So you need to take a wide excision. Okay, you need to take wide excision, which is what we do also for a lot of tumors. Okay, but this one extends beyond the gland or beyond the capsule of the tumor itself or the mass. So we need to take a wide base excision. Okay, so that's that. We're done with the face and skull. Do you guys have any questions till now? Or is everything clear till now? Good. This is where we'll start to go into clinical and a lot of these clinical concepts because that was pure anatomy and pathology. So if no questions, I will start this one. So now the nasal sinuses. We have four nasal sinuses or paranasal sinuses. We have the frontal, the ethmoidal, the maxillary, and the sphenoid. Now, if you have any disease of the sinuses, the best way for us to visualize these diseases is radiology. The gold standard is CT scan. Okay, so this is an X-ray, which will just show you the same thing. This is the sphenoid, and this over here is the sella tertiaca, which will sit the pituitary gland. These are the ethmoidal air cells, and we have three, anterior, posterior, and middle. Then we have the biggest sinus, which is a maxillary sinus. And then we have the frontal sinus, which my chat box is covering, is this one. Okay. Anyways, so we have these. These four sinuses will drain into the meatises in the nasal cavity, and we'll talk about them one by one. So now I want you to identify, these are CT scans. Which sinus is this one?
Frontal.
Frontal, ممتاز. This one, maxillary. This one, these, the blue ones,
Ethmoidal.
ethmoidal, and then this one,
Sphenoidal.
sphenoid. Now, what's very important when you look at the CT is you need to understand one major thing, is what is the floor of the orbit? Which bone? Which forms the floor? Other than zygomatic, what's important is maxillary, because what's right below this floor is the maxillary sinus. Part of the medial wall of the orbit, which is here, is the ethmoid, which will have the ethmoid air cells. So you will if you have maxillary sinusitis or ethmoidal sinusitis, it is very important that you treat it because it can spread directly to the orbit. Is the orbit a closed or open space? Closed. So infection will spread and will cause orbital cellulitis or some sort of very bad infection. Okay, the patient can lose their vision. Okay, that's what's important about it. Okay, and I'll explain sinusitis and all that in the next few slides, inshallah. So now over here, this is a very key radiology. He'll most likely, if any low yield comes, it's this one, is what is this structure over here in the ethmoid? This is very low yield, and I'm sorry for bringing this, but
Cerebriform plate.
no, it's not. The cribriform plate will be up here. But what will go from the cribriform plate into the nasal cavity? This is the septum in the middle. There's this structure over here that's coming from the cribriform plate and coming out into the nasal cavity, into the septum.
Olfactory nerve.
Other than the olfactory nerve.
Anterior and posterior ethmoidal arteries.
Anterior ethmoidal artery. This specifically, if you get it as a question, is the anterior ethmoidal artery. Okay? Again, very advanced radiologists get tested on this, not second-year medical students. But anyways, if you get a question on this, now you know. If there's an artery coming out of this ethmoidal bone into the ethmoidal sinuses and going into the nasal septum, it's the anterior ethmoidal artery. Okay? Let's see if it comes. Okay? So this is anterior ethmoidal artery. The reason I brought this is he said this is very important in your transcript. So let's see. Now you have the nasal cavity itself and the nasal sinus drainages. You need to know this in detail. So this forms the lateral part of the nasal cavity, and you have these turbinates or concaves, and then you'll have the meatus, which is under the turbinate or the concha. So you'll have the inferior concha, and under it is the inferior meatus, middle turbinate, and under it is inferior, the middle meatus, and the superior, and then the superior meatus. Now the inferior meatus will have one thing draining into it, which is what?
Nasolacrimal.
Nasolacrimal. How about the middle? You'll have multiple things.
All of them except ethmoidal.
All of them except posterior
Sphenoid.
ethmoidal and sphenoidal. Sphenoidal will drain into the what's it called? The sphenoethmoidal recess, and the posterior ethmoidal will drain into the superior meatus. What's important about this is if a patient has rhinitis. Rhinitis is inflammation of the nasal cavity of these, okay, the turbinates. If the patient has rhinitis, easily what could happen is blockage of these ducts, okay? Blockage of the ostia and the meatus, tamam? So what will develop afterwards if you have blockage of the meatus, of the ostia over here, is sinusitis, because that's what drains into it. So that's why we all usually call it rhinosinusitis, because it's both the same thing. Rhinitis can be complicated by sinusitis. Okay, sinusitis, there's bacterial and viral causes. In this case, it's usually bacterial. Why? Because if you have closure of this duct or this ostia, let's just say this one, because usually is the middle meatus and it's usually the maxillary sinus that gets inflamed. If you have blockage of this, the maxillary sinus will be full of fluid. This fluid is an amazing environment for bacteria. So bacteria will grow there and will cause inflammation. This is what we call rhinosinusitis. Tamam? This is why the nasal sinus drainage is very important and you need to identify everything here. Okay? Tamam. So now then, other than the nasal cavity, you have the nasal septum. Nasal septum is formed by three bones. You have the two bones and one cartilage. Perpendicular plate of the ethmoid, the vomer, and then you have over here is the cartilage. Now, if you have a septal deviation, most of the time it's the cartilaginous portion, which is the anterior portion. Sometimes it's the bone. Most common, it's the cartilage. So now when you do imaging, as I said, if you want to diagnose patients with a lot of these nasal cavity diseases, sinus diseases, we can do a CT scan, which will visualize it very nicely. So over here, you have this, which is a septum, easy. Then we have each of the turbinates, inferior, which is this lower one, middle, and then you have the superior over here. Again, below the turbinate or right behind it is the meatus. So the meatus of the meatus, which will have the ostia of the nasolacrimal duct, which will be over here. This will have everything except the posterior ethmoidal and the sphenoidal. This will have the posterior ethmoidal, then some over here will be the sphenoethmoidal recess. This sinus over here is the maxillary sinus. Okay. Now this is important because think about it. The duct is over here. Okay. So it has to go against gravity. So if you have a blockage of the duct, fluid will grow here. Bacterial infection, easy. Okay, but this duct has to be open. So that's basically that. This over here is, you need to look at, when you're looking at the image, the things that you need to identify is firstly, septum. Is it deviated or not deviated? Okay. The turbinate, is it normal, enlarged, or shrunken? Okay. Then the sinus, you look at the sinus. Does it have fluid? In this case, it's not. Okay, it doesn't have any fluid, which is good, or not. These are the things that you need to look at when you look at the image of the nasal cavity, okay? Clinically, we use an endoscope, which will basically look inside the nasal cavity, and this is what we do for a lot of patients with rhinitis, whatever the cause of rhinitis is. Sinusitis, we can see, not a lot actually, we don't use it for sinusitis, but we use it for rhinitis and nasal cavity diseases, okay? Or nasopharyngeal diseases, okay? It's basically a scope. No, this is normal. In this case over here, I'll show you abnormal, don't worry. In this case, it's a scope that we go inside the nose and it will basically allow us to visualize inside the nasal cavity. In this case over here, this is the nasal septum, this is the floor of the nasal cavity, and this is the turbinate. The turbinate, what we want to look at is the size, the color. It's very important, and if there's any discharge. Okay. What is the color of this turbinate? Simple, yani what pink or
Pink.
red? Yeah, slight red or pink. Okay, that's normal. If it's pale, it's abnormal. If it's very red, it's abnormal. Done. Okay, and we'll get to what causes each. This is middle turbinate and whatnot. Do you need to identify these diseases on endoscopy or rhinoscopy? No. Okay, but this is just to help you visualize or know some of these diseases. Now, as I said, if you have rhinitis, okay, bacterial or viral rhinitis, it's usually complicated by sinusitis. Why? Is because you have a closure of the duct that will cause excess mucus production, that will cause then basically the fluid to accumulate inside that sinus, which will cause it to be inflamed. Okay. So now, what are the symptoms? Firstly is rhinorrhea. Rhinorrhea is nasal discharge. In this case, usually it's bacterial infection. So what do we see is it's a lot of mucus, okay? Plugged nose, congestion, facial pain. Why? It's because over here you have the frontal sinus, you have part of the ophthalmic nerve, some of the terminal branches, which will go near it. So since it's inflamed, it will irritate the nerve, hence headache. Maxillary, same thing, okay? Obviously a different branch. But you'll have facial pain. You'll have fever because it's infection, okay? And you'll have headaches. Another thing is, especially with maxillary bacterial sinusitis, is you'll have facial fullness. Your face will feel full, okay? So how do you know this patient has bacterial sinusitis or bacterial rhinosinusitis? Is firstly, again, what's usually the original cause is rhinitis, tamam? This patient will come to you with nasal discharge, they're feeling sick, common cold, okay, with viral rhinitis. 7 days later, they're supposed to get better, but they get worse. This usually means that they had bacterial infection, usually of the sinuses with these symptoms afterwards, okay? So again, you have a patient who comes with rhinitis. They start to feel better, and then 7 days later, they get worse because of bacterial infection. Another thing is if they start developing a high fever, okay? Rhinitis, if it's viral, which is usually the case, should not develop a high fever. If they start developing a high fever, this is going to be bacterial sinusitis, okay? Another thing is if they don't improve. If they firstly develop rhinitis and they slowly get worse, this means that it's slowly involving the sinuses with these symptoms. Okay, and this is important for you to remember. Now we go to this, okay? What is happening here? What's the diagnosis?
Deviated septum.
Deviated nasal septum, good. Okay, so deviated nasal septum, what's important about it is, just remember, is we don't usually rush and do surgery for these patients. We usually do it if they have severe dysfunction because of it, which is because of breathing dysfunction. Then we go. But usually we don't, or it's cosmetic. That's it. Tamam. Now we go to rhinitis. This is clinical. Rhinitis, we have two important subdivisions of rhinitis. Allergic, non-allergic. Tamam. So allergic. From the name, what are the common allergic diseases that you know? Common ones. We have this one, rhinitis. Eczema, if you remember from MSI. Okay, and then one that you learn very soon, which is a very common respiratory disease, is asthma. Very similar to all of these, is if you have a specific allergen that you're allergic to, and then suddenly you have rhinorrhea, discharge, you're sneezing a lot, you have congestion. This is allergic. You're allergic to that specific substance, okay? This is an allergic disease, an atopic disease, okay? So you'll have watery rhinorrhea, sneezing, nasal itching, congestion in response to a specific trigger. This is a very important finding, okay? And it's associated with a history of other atopic diseases, such as asthma and eczema, or allergic conjunctivitis. This is crucial and high yield allergic rhinitis, okay? Now, if you check for the endoscopy of the nose, you'll see it pale, and this is just important about specifically allergic rhinitis, tamam? Now, this is in response to something very specific, and it's an allergic reaction. So what antibody will be elevated in allergic reactions?
IgE.
IgE, ممتاز. IgE, okay? So it's IgE specific. So how do you diagnose these patients? Firstly, clinically, they'll tell you, oh, يعني مثلا here in Saudi, you go outside, it's dusty outside, you start sneezing, nasal congestion, itchy. Plus, you're allergic to dust, clearly. You go away from the dust, it goes away. You're avoiding the trigger and it's solving the problem. Allergic rhinitis. That's number one, clinically. Number two is you can do specific immunological testing. You can do IgE skin test or IgE lab test. Skin test, you prick the patient with allergens and you see comparing it to like a histamine reaction. Okay. So you'll see the size of the allergic reaction of the allergic reaction that you see on the skin, and you can see whether or not this patient has atopy to that specific substance. Okay. Then you can do blood tests, which will you can see, for example, elevated IgE, and you can test for the specific IgE to that specific allergen. Okay. Now the age is usually earlier. It's associated with other allergic diseases, which will come in the case. And now treatment. Straightforward. You're allergic to something specific. So what do you try to do? Avoid it. Simple. Solves the issue. Let's just say they can't, or it's very hard, مثلا dust outside, it's very hard to avoid it. So you can take intranasal steroids, this is very important. Or oral antihistamines. Now there's another medication that you can also give, which is nasal decongestants, which are alpha agonists, such as oxymetazoline and whatnot. In this case, it's very high yield. For you to remember is we use it for a few days, not that long. We use it مثلا 5 days only, 3 days, that's it. We use it when we're trying to avoid or an acute episode of rhinitis. We don't use it any longer than that because you can get a rebound congestion afterwards. Then we have something called immunotherapy. Okay. Now, what is the concept of immunotherapy? Is you inject the patient with the allergen very slowly, low doses for years, 3 to 5 years. Usually, because of this slow exposure of the allergen, they will desensitize. Their immune system will be used to that allergen and khalas, they won't be allergic to that anymore. What's important for you to remember is you will not see a response in 12 months. And number two is it's done in a clinical setting because you might induce very severe allergic reaction. Then we go to non-allergic rhinitis. From the name, it's not usually associated with allergies. Okay, so there's no clear identified factor or trigger that causes the rhinitis. One of the more common ones is vasomotor rhinitis. In this case, you have nasal congestion, rhinorrhea, postnasal discharge, which is discharge that's happening in nasopharynx into the mouth. And it's not in response to something specific. So مثلا is if you go into your car and you turn on the AC and the air blows into your face, you start sneezing. This is vasomotor rhinitis. مثلا you get a wind blown in your face, you start sneezing. This is vasomotor. There's no specific allergic trigger. Okay. Treatment of this is intranasal antihistamine or steroids, and if it's severe, you go for both. But anyways, you don't need to know this detail over here. And that's basically rhinitis in a nutshell. We'll go into each specific cause. Then we go into infectious, which is also non-allergic. In this case, it's very simple. It's because of infection. There's viral and there's bacterial. Viral, the most common is rhinovirus, and you have corona, adeno, influenza, and so on. Then bacterial infection, which happens above it, superimposed. There is acute, there is chronic. Acute, he also put the doctor methane, bronchilosis, carbuncles, all these things that happen externally and then spread into the nose. Then chronic. Chronic is some bacteria. In this case, what is this one? This is very low yield, not gonna lie, it's syphilis, but this type of nose appearance, the saddle nose, is very high yield in board exams. Okay. But I just put it in case if he tries to go any low yield causes of chronic bacterial rhinitis, it's gonna be this one. Okay. Anyways, this is infectious rhinitis. What's important about infectious rhinitis is association with sinusitis. Okay, which we'll get to inshallah. Which is this case. What is this disease? What's the diagnosis?
Maxillary sinusitis.
Is it only sinusitis?
No idea.
Okay, so this is both rhinosinusitis. Look at these turbinates. It's the same as the picture I showed you, same size. These turbinates are so huge, much bigger than this side. Okay, this is the left, this is the right. The right side is much bigger than the left. So this is rhinitis plus fluid in the maxillary sinus. This is rhinosinusitis. Tamam. This is maxillary sinusitis, and that's pretty much that in a nutshell. Now, as I said, is how can you tell this patient developed rhinosinusitis or that's bacterial? It's, as I said, is if they started to get worse after the initial episode. Tamam. That's important. Now, what's also important about this is what's it called? Is you treat this with antibiotics. You do a CT scan, you check the sinus, it's infected, then you give antibiotics. Simple. Okay. And you usually give penicillin or slash amoxicillin. Okay. That's pretty much that. And if they have allergic reaction to that, you give a macrolide. That's it. Then you go over here, which is what?
Cellulitis?
Not cellulitis, but it's chronic sinusitis. You can see that the turbinates are a bit smaller than acute rhinitis. But then over here, there's small amount of fluid. Okay, there's still fluid. There's not supposed to be this much. What I want you to remember from chronic sinusitis is fungal infection. Okay, which is this sign over here. In this CT scan, okay, you can see a lot of fluid with septations. This is fungal infection. Why is this important? Is there some fungi, such as mucormycosis, that will cause necrosis of these bones, and it will spread into the bone and cause death very fast. So this is a fungal cause, and I want you to remember this image specifically. Okay, this is chronic sinusitis, which is over 12 weeks. Okay, of the acute infection, which is this one. This image, by the way, is memorized. You need to memorize this. Now, if you have a patient with this, in this patient over here, you can look at the turbinates. What's happening with the turbinates?
Shrinkage?
Shrinkage. In other words, is atrophy. Okay, chronic atrophic rhinitis. You can see some discharge over here, but here it's very small turbinates. Why is this so? It's either because of chronic infection, but the most common cause of atrophic rhinitis is surgery, surgical removal. And this is what's left from the turbinate. That's pretty much that. Okay. This is chronic atrophic rhinitis, small turbinates. Okay. Now, this needs a history before you diagnose it, because by looking at it, it's rhinitis, simple, and large turbinates. But if I tell you this patient had allergic rhinitis and has been using the decongestant for 10 days, and they got worse. Or you started to get nasal discharge, rhinorrhea, congestion, sneezing, far worse than before. What is this called? They started taking the decongestion, they got better, but then they started to rebound. This is called, excellent, rhinitis medicamentosa. This is rebound congestion because of overuse of the decongestant. You might ask me, this description of getting better than getting worse, this might be sinusitis. They don't have fever, they don't have maxillary fullness, they don't have facial pain, they don't have headache, but they have the rhinitis symptoms again, okay? The congestion, the rhinorrhea, and so on, with the use of decongestant for multiple long days. This is rhinitis medicamentosa. How do you treat this? Simple. Stop. Stop using the decongestant. Tamam? This is important. And it will be given to you like this in a case. Okay? Then we have over here, we look at inside the nose and we see this mass that is fibrovascular. What is this?
Adenoma?
No adenoma.
Polyp?
Not collagen. Polypus, good. So polyp. Now, polypus rhinitis is usually because of polyps, okay? And ignore these two, but anyways, usually because of polyps. Now, when do polyps generate? It can be either on its own, okay? Or, very important, is cystic fibrosis patients, or something called aspirin exacerbated respiratory disease, okay? If we use aspirin, and this develops polyps, asthma, and so on, then they develop aspirin exacerbated respiratory disease, okay, which is this polypus rhinitis. So what do we do with these patients? We remove the polyp surgically, okay, simple. Tamam. Now going into the last concept of the nose, which is the nasal cavity blood supply. The blood supply is by both the internal and external carotid artery. So the internal carotid artery will give off the ophthalmic artery, which will give off the anterior and posterior ethmoidal artery. So the anterior and posterior ethmoidal artery will go into the nasal cavity and then will go supply the septum. This is from the internal carotid. External carotid will give off the facial artery, which will give off the superior labial, which will go into the nose, and then we'll go and anastomose with the rest of the blood supply. Then we have this sphenopalatine artery, which will go and supply the nose as well. There's going to be a plexus over here, which is the Kesselbach's plexus, okay? This is the most important site for a disease, which is what?
Epistaxis.
Epistaxis, anterior or posterior? Anterior epistaxis, excellent. This is anterior epistaxis, okay, which is bleeding from the nose. The most common cause of epistaxis in this case is dryness, okay, especially in this weather. Tamam. Then we have back here the sphenopalatine artery, which will also form a small little plexus over here, which if it's damaged by any reason, this is going to cause posterior epistaxis. Which one is more dangerous, anterior or posterior? Posterior, which will go and might cause aspiration and choking and so on. Tamam? Good. Now, this is going into the details of epistaxis. Is bleeding from the nostrils anterior. If they're bleeding from behind, it's posterior. Okay, most common is anterior. Peak incidence is children in this case. And very important thing is in children because of dryness. So usually in the treatment, later on, I'll explain the treatment modalities. You just give lubricants. Also, children have a propensity to poke their nose and pick their nose, so that will cause irritation and will cause bleeding. Now, posterior is more dangerous and could cause aspiration, choking, and so on. Now, also another thing is how do you treat it? When you have a patient acutely with epistaxis, there are steps that you need to take. First step is, because this is very vascular and you need to treat it immediately, is number one is compress the nose. Hold the nose from outside. Compress it for 5 to 10 minutes. Before that, actually, you do something called ABC, which is airway breathing circulation. You'll learn this in more detail when you go to 5th year. But you firstly make sure the patient's stabilized. Then you pinch the nose and you bring the head forward, okay? Bend it forward, okay? This will usually stop the bleed most of the time. If this doesn't work, you cauterize, okay? Which means is you basically burn the blood supply, okay? Which is this point over here. Usually would stop. If it didn't stop, then you anteriorly pack it with a tampon method. If it didn't work and it starts to bleed posteriorly, you go to the OR. For posterior epistaxis, you do posterior clogging. Or it's posterior packing. How do you do it? It was with a catheter. Okay, so I'm going to repeat this again because it's important, kind of. Epistaxis. Anterior is more common, usually due to dryness. Okay, most common cause. How do you manage it? First step for anterior and posterior is airway breathing circulation, ABC. Anterior, the blood supply or the damage is right here in the frontal portion, anterior portion of the septum. So you compress 5 to 10 minutes. Okay, the Trotter method. Exactly. 5-10 minutes, head bend forward. Usually you will stop. Doesn't stop, cauterize. Doesn't stop, anterior pack until it stops. Doesn't stop, surgery. Okay. Posterior, you need to posterior pack it with a catheter. Is this clear? Do you need to know all of these steps? No. Okay. But this is for you to explain because he put it all for you, but actually in reality, it's steps that we follow. Okay. This comes first, then this, then this. What you need to remember is a location, which is the Kisselbach's plexus, and the cause, which is dryness and usually, or children being children and picking their nose. And this method, the pinching of the nose, is very important. Now, if you have a patient with a teenager with unilateral epistaxis, what is this? In teenagers, if you have a unilateral epistaxis, this is juvenile angiofibroma, okay, which is a very important cause of unilateral epistaxis. That's all I want you to remember, and this is an imaging that's showing you on the right side. Tamam. The nose, nasal cavity, sinusitis, rhinitis. Is everything clear till now? Tamam. Let's take a 5 to 10 minute break, 10 minutes. We'll come back at 8:40. Okay. طيب. Now we're gonna go over inshallah the rest of the spell, which will be the oral cavity and throat, and then inshallah we'll end it with the ear. So with the oral cavity, we'll start over here, which is just the teeth and sorry, one second. The teeth and the rest of the oral cavity. So for the teeth, how many teeth do we have? We have 32. Okay. We have the front two incisors, the premolars, then we sorry, the canines, then we have the premolars, then the molars. Okay. Now, usually most people will have around 28 to 32 teeth because of the wisdoms, and people usually remove it. Now, looking at the teeth structure itself, we have over here the crown, okay, which is the top part of the teeth. There's multiple surfaces of the teeth. This is the crown of the teeth, which will have the enamel, which is the hardest part or hardest bone structure or calcified structure in the entire body. Then we have the dentin, and deeper to the dentin is the pulp. Now, how does the tooth itself, root, connect to the bone? Is firstly from the root, we have some structures such as a cementum and a periodontal ligament, which will attach to the alveolar bone. This is all three layers that are very important. Why is that so? Is because certain infections, guys, can you give me just 1 minute? Sorry. Can we resume? So now what's important is the infections. Okay, so in the teeth itself, if you have, for example, bacterial overgrowth, it will develop a lot of, for example, this matrix over the tooth, which is the caries or the plaques. This will start to erode the teeth. So it will erode through the enamel into the dentin, then the pulp. Then from here, it can spread to the adjacent structures, such as the gums. So it will cause the pathology called gingivitis. تمام. Then if it goes past this and goes through the cementum or involves the cementum, the periodontal ligament, or the alveolar bone, this is what we call periodontitis. Okay? This is important. Now over here, what's important is the different cells or the cells that produce the certain structures of the bone, okay, of the teeth. So we have odontoblast and then we have the ameloblast. The ameloblast will produce the enamel. The odontoblast will produce dentin. Why is this important? It's because of the different tumors and what they produce. Tamam? So now we go into it one by one. Over here, you have this structure that's forming, or membrane that's forming above the tooth, usually because of poor dental hygiene, bad diet, for example, high carbohydrate diet, sweets and stuff. What is this called?
Plaque.
Plaque. ممتاز. Plaque. How do we prevent this? Good oral hygiene. And then we can also fluorinate the water, which is what happens in the US, is fluorinated water. And this will help protect the enamel. Okay. Then we have this. If it starts to erode into the enamel, what is this?
Caries.
Caries. These are cavities or caries that are formed in the teeth. So you'll have into the enamel, then into the dentin, then into the pulp, and then it will start to surround the different structures. So if it goes into the gums, we call it gingivitis, which is usually because of the gingival plaques or the caries. Or if it goes through the cementum, the periodontal ligament, the alveolar bone, this is what we call periodontitis. Tamam. Now over here is you have inflamed gums. So what do we call this?
Gingivitis.
Gingivitis. Okay, and it's usually because of the plaques that are located around the gingiva, right, the gums. Over here, because of long-standing inflammation, you have gingival hypertrophy. Tamam. How do we know this is gingivitis or gingival hypertrophy? And not just by looking at it, is they'll tell you a clear thing, which is A, they have cavities or a lot of plaques, they have poor dental hygiene. Another thing which is high yield, which is whenever they brush their teeth, it starts to bleed. This is because of gingival irritation. Tamam. Gingivitis, gingival hypertrophy. And that's pretty much these two. Now, because of the gingival, exactly, because of the gingival plaques, it can spread through and it goes through the cementum, periodontal ligament, and the alveolar bone. What do we call this disease? Periodontitis. Good. This is periodontitis. What's very bad about these is untreated infections of the teeth can spread and cause multiple things, such as cavernous sinus thrombosis, brain abscess, so many other things. So that's why it's very important to A, prevent this by good oral hygiene, and number two is you treat it whenever there is, okay, these diseases. Then we go to this disease. What is this? A very bad smell, halitosis, bleeding, gums, and it's an infectious cause. Not Ludwig. Ludwig is here. The other angina. Vincent angina. Good. This is Vincent angina, which is a polymicrobial infection caused by gram-negative and spirochetes. Okay, so the gram-negatives are like Bacteroides, Fusobacterium, and so on. Then you have the spirochetes. Okay, this causes Vincent angina, which is acute necrotizing ulcerative gingivitis. Okay, so it's gingivitis. And it's polymicrobial. Okay. Then now we go into the dental tumors or cysts. Over here is you have a cyst that forms on the apex of a teeth or a tooth. What is this? This is high yield.
Abscess.
Not abscess. It's not infectious. I mean, it does happen because of pulpitis or infection here, but this is a reticular or periapical cyst. Tamam. Again, key thing is that this is number one, the most common cyst that happens in the oral cavity or the around the teeth. This is periapical. It's right next to the apex of the teeth, which is this point over here. And it's usually because of pulpitis, which is inflammation of the dental pulp. Tamam? Just to tell you guys, these are dental implants. This is the actual tooth, okay? Because this are implants most likely because, or fillings most likely because of the pulpitis that happen. This is most likely a root canal. So here, this is a radicular or periapical cyst. Tamam? This over here, same thing. This is CT showing you a cyst this is of the mandible, and this is a cyst below the teeth at the apex. Same thing, cyst below the apex. Tamam? This is high yield. Then over here, which is the most common congenital cyst, which is this, which is formed at the crown of an unerupted tooth. Crown of an unerupted tooth. Dentigerous cyst or follicular cyst. What's high yield is this is most likely the the wisdom tooth that did not go out yet. Okay, that's why it's unerupted tooth. And then you have a cyst that forms at the crown. This is the crown of a tooth. When this forms, this is what we call a dentigerous or a follicular cyst. To look at it again, this is the unerupted tooth. That's why it's in the lower mandible. And then it grows around the crown of the tooth. This is a dentigerous or follicular cyst. It's the most common congenital tooth or teeth cyst. Okay? Tamam. Then we have this. Located at the angle of the mandible or at the mandible. It's not related to the tooth itself. It's just a cyst that forms. What is this? If you see histology, it has a lot of basal cells. This is what we call odontogenic keratocyst. What's high yield, very, very, very high yield about this is its relationship with basal cell carcinoma. Why? Is because you can see the basal cell hyperplasia over here. Okay, so this will start to grow in number, become more dysplastic, and form multiple basal cell carcinomas. This is odontogenic keratocyst. This is high yield. Okay, to remember this feature of it. And it's not related to the apex of the tooth, and it's not related to the crown or whatever of the molar. Okay. Then we have here, which is a very important or one of the more common masses or dental masses, which is an odontoma. So in an odontoma, it's a growth it's a growth of dentin over here. You can see a lot of dentin that's in wrong spot. Okay, so it's just like a hamartoma, if you remember from POD. Hamartoma is normal tissue in an abnormal place. There's a lot of dentin here that's not supposed to be there. It's because of certain cells that's producing dentin, which were the odontoblasts. So that's why we call it an odontoma. It starts to produce a lot of dentin that will just stay in this area. Okay, there's not much about this other than the fact that it secretes a lot of dentin, which is all of this. Then here, which is more tumor-like, which is this, which is ameloblastoma. Okay. So that's for the dental diseases. Now we go to the oral cavity, the rest of the oral cavity. The first one here is this patient has an ulcer, good, that arises, female patient ulcer produces or increases with stress. What is this called? Aphthous ulcer. Good. So aphthous ulcer is the most common ulcer that happens in the oral cavity, and it's because of usually it's stress. Usually recurs multiple times. It's painful, has some erythema around this small little exudate that happens, and it's not that raised, okay? And it goes away on its own. This is an aphthous ulcer. How about here? What's this disease? This is HSV, or human simplex virus, or herpes simplex virus. Sorry. Herpes simplex virus. Herpes simplex virus is a sexually transmitted disease. Another form of this, there's two forms of it. There's HSV1, which is oral, and then HSV2, which is genital. تمام. This is also what we call a cold sore. Okay. So this is herpes simplex virus, happens in oral cavities because of HSV1. Okay, and it's painful vesicles. You took this somewhat in MSI, remember. And it's characterized by these cells, which are multinucleated giant cells. تمام. This is HSV, and it's usually HSV1 that causes the oral lesions. Then you have this patient. This is a baby, obviously, but let's just say a patient who's asthmatic, taking inhaled corticosteroids for a long term, and then develop this. What's this?
Oral thrust.
Oral, yes, oral thrush, or what's the organism?
Candida.
Candida, but oral candidiasis or oral thrush. And it's basically overgrowth of candida. In the oral cavity, it's usually because of steroids, okay, immunocompromised patients. In this case, the most common cause of that is because of asthma patients who are taking inhaled steroids. And they don't use a spacer or they don't wash their mouth after they use the inhaler. This is what causes the candida infection. Now, um, what's important about this is, can you scrape it off? Yes or no?
No.
Yes. This one, yes. Candida, yes. This is important. Candida can be scraped off, and when you do that, it starts to bleed, but it scrapes off. تمام? This is an important differentiating point from two other pathologies that we'll get to. تمام? This one is something called erythematous candidiasis. And the important thing about this, if you look at this, does this patient have teeth? No. So what do you think they wear during the daytime and they take off when they sleep?
Denture.
Dentures. Good. So what's important about erythematous candidiasis is dentures. It's elderly denture related. The dentures will hold a spot that can grow the fungi. That's the high yield point of erythematous candidiasis. Candida diagnosis, you know more in detail from POD, more likely, but it's very simple. You take culture, you grow it on this agar, and then you can see germ tube formation. If you put it under just normal microscopy, you can see that it's gram positive. And then germ tube positive for example, Candida albicans, which is the most common one. Well, that's basically this, very simple. And you can just diagnose it clinically based on the features and the risk factor. Plus, if you scrape this off, it will scrape off most likely Candida. Now, you have this patient who was a smoker for 30 years showing up to you with a mass, or not a mass, this white lesion that's located on the lateral tongue. You try to scrape it off, you can't. What is this? Leukoplakia, good. Leukoplakia, think of it as a precancerous lesion, or the risk factor developing that will develop into cancer, and it's usually because of smoking. It's characterized as a white patch that you cannot scrape off, and it's most likely in the lateral tongue, and it's more likely because of smoking. That's the key things in the case scenario that they usually bring to you. Tamam? This is leukoplakia. Now, what's important is also the histology. Now, if we have, remember from MSI derma, is if you have all the stratum layers, if they're larger in size, this is acanthosis. If you have the stratum corneum, it's increase in size, it's hyperkeratosis. If that stratum corneum, which shouldn't have any nuclei, has nuclei, what do we call it? Parakeratosis. Excellent. So these are the three findings. Acanthosis, thickening of the entire layer of the skin. Hyperkeratosis, which is increased thickening of the stratum corneum. And then parakeratosis, which is nuclei inside the stratum corneum. These three features, plus signs of dysplastic features, such as abnormal nuclei, increased NC ratio, all these things. This is leukoplakia. This is again precancerous. It would not invade the basement membrane yet, and it's still not fully dysplastic. Okay, leukoplakia. And can this develop into squamous cell carcinoma? Yes, it can. What's more high risk is this one. What is this? Erythroplakia, good. Instead of white, it's red. Think of it as that. Instead of it being a precancerous lesion, it is a cancer in situ. That's next step. Okay. So this is erythroplakia. Okay, it's red from the name erythro. Okay, and if you see on histology over here, is that it is basically squamous cell carcinoma in situ. Okay, it did not invade the basement membrane just yet. This one has a much higher risk of developing into squamous cell carcinoma. Done. Erythroplakia. Now you have an HIV positive patient who presents with two velvety lesions on the tongue, lateral tongues. You cannot scrape it off. Hairy leukoplakia. What's the organism that's associated with it? Again, it's HIV patient. It's more specifically EBV, I think. Yes, EBV. So hairy leukoplakia, HIV patients, so immunocompromised patients with EBV positivity, and you can see these velvety lesions on the tongue, white velvety that you cannot scrape off in an HIV patient. Hairy leukoplakia. Does this have malignant transformation or risk of malignant transformation? No. Okay, that's the difference between them. Now, let's just say that you had a leukoplakia patient that did not care and continued smoking and developed into this. What is this? Squamous cell carcinoma. How can we tell the difference between this and leukoplakia or erythroplakia? It's ulcerative, it's erosive. It starts to invade inside. So it starts to bleed, come on. You take a biopsy, whether or not this patient has erythroplakia, leukoplakia, or whatnot, you take a biopsy just to make sure that this patient does not have this. You take a biopsy, you see this. What are these things called? You took MSI, so this should be quick.
Onion something.
Keratin pearls, okay? Keratin pearls, balls of keratin. Over here, what do we see in between the cells? Desmosomes, okay? So you have oral squamous cell carcinoma. The most common risk factor is smoking, but there's a viral cause of it. What's the virus? There's a virus that's associated with, say it again.
HPV.
Mumtaz. HIV, HPV, sorry. So HPV, there's multiple types of HPV. We'll get to laryngeal papilloma, which is serotypes 6 and 11. Then we have the cancerous ones, which are 16, 18, and 31, which is what causes this squamous cell carcinoma. So HPV associated is in younger patients, okay, usually in the oral pharynx, or even in the oral cavity. Now, the mutations is few. Pathogenesis is basically E6 and E7. You'll learn this in detail in repro in third year, very later on. But basically, you have two proteins, okay? E6 will inhibit P53, E7 will inhibit retinoblastoma, which are tumors, which are basically checkpoint. So they inhibit the checkpoint in the mitosis. So this will cause abnormal cell division, uncontrolled cell division, tumor, cancer. تمام? And the outcomes of this is good because it's usually detected earlier and better history. Not associated HPV is a smoking, tobacco related. تمام? So yeah, that's basically the difference between them. And that's done with the oral cavity. Now we go into the the pharynx and the tonsils. So when we look at the oral cavity and we look at the pharynx and tonsils, we look at specifically the pharynx. Is it normal in color, which is slightly red, slightly pink? Or is it very red? Is it cobblestone? Does it have exudate or erythema? Erythema is redness. Then we look at the tonsils. This is the normal tonsils. If it's enlarged, if it has exudate, does it have crypts? Does it have a membrane over it? These are the pathologies that we look at in the tonsil. So what symptoms will any of these two, either pharyngitis or tonsillitis, have? Pharyngitis will have both of them. Sore throat, difficulty swallowing, bad breath, halitosis, excellent, good. Sore throat. They might have other symptoms as well, like other manifestation, difficulty breathing if it's very large, or they have a complication of pharyngeal tonsillitis, such as otitis media, okay? Such as peritonsillar abscess, such as brain abscess. So they might have other complications because of this. Tamam? So that's the pharynx and tonsils. Obviously, I mentioned all these things, and I'm going to go through each of these things that I mentioned. The first thing is in pharyngitis, you have this. Okay, this is pharyngitis, tamam? Acute pharyngitis, just to give it to you. What's the most common cause of pharyngitis? Is it bacterial or viral, usually?
Viral.
Viral, excellent. But what's bad is you need to differentiate viral and bacterial. Why is bacterial bad? What's the most common bacteria causing bacterial pharyngitis? Strep pyogenes, good. Okay, strep throat. So in this case, you need to tell the difference between them. Okay, how do you tell the difference clinically? Tamam. Number one, this is in children. So the age is usually less than 15 that they develop this. And then now you need to know the difference clinically. If they start coughing, this is usually viral. Okay. No cough is usually an indicator of bacteria. This is just something fun fact for you to know. Fever is bacterial. Excellent. Now, if you see this, what is this? Lymph node, cervical lymphadenopathy. If you see this, is it more likely bacterial or viral?
Bacterial.
Excellent. Now, you can see over here, the tonsils or the whole pharynx look red, inflamed. Here, look at the tonsils. Does it have an exudate? Yes. So is this viral or bacterial?
Bacterial.
Bacterial. If you start to see exudates like this is bacterial. Okay? تمام. It's usually strep pyogeny, sorry. Why is it important for you to detect this or know the difference between viral and bacterial? Is once you have a suspicion that this patient has bacterial, you take أول شيء very fast in the office is rapid strep test, swab. Done. Next thing is you need to do throat culture. Then you need to treat this with antibiotics if you're suspecting it's bacterial. If you're not suspecting that's bacterial, you can treat if it's viral. So for example, if they have a cough, no fever or low grade fever, if they have no exudates and no lymphadenopathy, it's viral. So how do you manage them? Supportive. What does that mean? Go rest in the bed, drink a lot of fluids, take paracetamol and Panadol. Bas. Done. Stay home. If you suspect, if they have, for example, no cough, high fever, this plus this, bacterial. No, I want to treat you with antibiotics. Tamam. Now, why do we need to treat them with antibiotics? Is long-term complications of strep pyogenes, group A strep. What are the two complications? Long-term complications. POD. Sketchy. Remember. Rheumatic fever, excellent, because of the M protein. Good. And what's another one? The other one is excellent. Post-strep glomerulonephritis. ممتاز. Post-strep glomerulonephritis. Excellent. So these are the two complications that happen because of strep pyogenes. So that's why you need to treat it accordingly, very fast. There's something else I wanted to say. Now, if you're suspecting bacterial pharyngitis, you take a throat culture and you send it for analysis and for drug sensitivity. Now, if you're also suspecting strep pyogenes, you can test for anti-streptolysin O, which will tell you for long-term complications and previous history of strep throat. Then, so what's this? Gram-positive cocci and chains, bacitracin
Pneumonia.
sensitive, bacitracin sensitive, and beta hemolytic and anti-streptolysin O positive pyogenes. If it's alpha hemolytic, which bacteria would you think it is? Remember, Streptococcus species, two beta hemolytic, two alpha hemolytic. Beta hemolytic, pyogenes, and agalactia. Alpha hemolytic, strep pneumo, and strep viridans. So this is beta hemolytic. If it's bacitracin sensitive or susceptible, it's strep pyogenes. If it's not, it's agalactia. Then we have other tests you can do, such as anti-streptolysin O, which will tell you that this patient has a previous infection or one of the complications. That's strep pyogenes. Now over here. Over here, you have a patient coming to you with this thick membrane that's over the pharynx and the tonsils. Membrane. What is this diagnosis? Diphtheria. Corynebacterium diphtheria. Excellent. Good. So Corynebacterium diphtheria is this gram-negative rod. Gram-positive rod, sorry. Gram-positive rod that is, if you strain it with methylene blue, has the metachromatic granules. Now about this is that it has an exotoxin, which is a B exotoxin. A binds, B does the stuff. تمام. What is the stuff that it does? It causes ADP ribosylation of elongation of factor 2, which inhibits bacterial synthesis, protein synthesis. تمام. Why is this important for you to remember, other than just knowledge? Is you need to know which are the toxigenic strains of diphtheria. تمام. What is the test that you do to diagnose patients with toxigenic strains? This one over here. This is called the ELEX test. تمام. This will test for the toxigenic strains of diphtheria. تمام. So how you do this is this filter paper, this one in the middle, has antitoxin. تمام. This one and this one are controls. This one is a known toxigenic. We know that this is toxigenic. We know this one is not toxigenic. This is the unknown patient sample. How does this work? This is the known toxigenic, صح? This is the filter paper that has the antitoxin. If it starts to precipitate in between the two, like this, that means that there's toxin binding to the antitoxin, producing this line. This means that this sample has a toxin. Looking into this one we know is non-toxigenic. So, would you suspect to see a line of precipitation between this and the filter paper? No, because we know that this doesn't have toxin. Then we look at the unknown, which is this patient. Can you tell whether or not this patient has a toxin, yes or no? Do they have the toxin, yes or no?
Yes.
Yes, because it precipitates between the two. That's what you need to know for diphtheria. Then this one. This one is a patient who has sore throat around 10 days with high fever, with some rashes as well, and with splenomegaly. What is this? Splenomegaly. Infectious mononucleosis. Excellent. This is also called Kissing's disease. So this is infectious mono, which is caused by what virus? EBV. Okay, good. EBV. Tell. How do you treat this? Is supportive. You tell them just go home and don't try to limit contact. And what's very important is you tell them to not play any contact sports for 4 weeks. This sometimes comes in your exam. And what's important is because of spleen. Spleen, you hit someone, rupture. Bleeding, death. تمام? Splenomegaly. So you tell them, don't do sports in general or exercise 3 weeks. Contact sports such as American football in US, 4 weeks. Okay, that's important. And swollen lymph nodes is another important finding of infectious mononucleosis. This is what you see with infectious mononucleosis. You can see atypical lymphocytes, huge lymphocytes, and then you can do the monospot test, which will check for agglutination, which is for EBV. Then we go into details of the types of pharyngitis. Okay, I'm going to go quickly here because it's advanced. I will tell you the key points of each, but I don't think you will be asked to identify based on image. This will most likely not come. If there's something that will come, I'll tell you. This is chronic pharyngitis, which will form these papules in the back, okay? What's important about chronic pharyngitis is you need to know the most common cause of chronic pharyngitis. What is the most common cause of chronic pharyngitis? Do you guys know? No, it's not. Repeated infection or long-term infection can cause it, but there's a more common cause. Okay, I'll tell you. The most common cause of chronic pharyngitis is gastroesophageal reflux disease. Okay, what is this? Is if you lay down, مثلا most of these patients lay down, they complain to you that when they wake up, they feel heartburn, haragan. Okay, because of reflux, Their esophageal sphincter is lax. Their lower esophageal sphincter is lax. You'll learn this in detail in GI. It is relaxed. So reflux can easily happen. When it happens, it can go up all the way to the throat and cause a raspy voice, chronic pharyngitis. This is the most common cause of chronic pharyngitis, and this is something I want you to remember. GERD, gastroesophageal reflux disease. تمام? And it's one of the three most common causes of chronic cough. This is something else that I want you to remember. This over here is granular pharyngitis, which is usually seen in viral infection. This is keratosis pharyngitis, which is the stones. If you saw, this is in the tonsils most likely, but this is what causes the very stinky breath in tonsillitis or pharyngitis. Okay, I don't suspect you guys to get asked about these. This is acute catarrhal or superficial tonsillitis, which is seen in viral. This is what we see in viral. You can see it's red, but there's no exudates. This is why we said if we see exudates, this is most likely bacterial. No, what's it called? No exudates, usually viral, so what we call acute catarrhal or superficial tonsillitis. Red only. This is usually viral. If it starts to form crypts, which are these invaginations into the tonsils, this is what we call acute cryptic tonsillitis. This allows for a space for the bacteria to go into the tonsils and grow in the tonsils. Tamam? Then it starts to form exudate or follicles. These are the exudates that form. This is bacterial. Easy. This is, when you see this, you know this is bacterial tonsillitis. You take culture and you treat it with antibiotic. Then you have the membrane that form over the tonsils and surrounding structure. If you see membranous, just think that this is a later form of this follicular tonsillitis or diphtheria. Think of one of them. Okay. And what's important about treating diphtheria is complications such as cardiomegaly and neuropathy. Okay. So that's just FYI. Here is parenchymatous tonsillitis, which happens a bit later. Again, what I want you to remember is membranous. I want you to remember this, which is exudates, which is bacterial, indicating bacterial. This is catarrhal, which is viral, red, no exudates. And then I want you to remember this one, chronic pharyngitis, is because of GERD. Okay, that's what I really want you to remember. And also granular is because of GERD. I said viral, no, it's GERD. Sorry. There's a lot of info here. So now, most patients with pharyngitis or tonsillitis, we treat them supportively and with antibiotics. If we know it's viral pharyngitis, we treat them with if it's viral pharyngitis, we send them home. We treat them with high fluids, drink a lot of fluids, take antipyretics, which is pain medications, and fever-reducing medications. That's it. Okay, stay home, rest. If we know it's bacterial, we treat them with antibiotics, which is the first line, amoxicillin, or penicillin. If they're sensitive or if they're resistant to that, or they're allergic to that, we give macrolides. That's all you need to know for antibiotics. Now, we have a procedure, which is called tonsillectomy, which is surgical removal of the tonsils. Okay? There's two things I want you to remember. The absolute indication, okay, and the complication. That's all I want you to remember. I'll teach you this. So tonsillectomy, if you remember from in children, is these tonsils can get very big in children. So if you think about it, would it obstruct their airway? Could it? If they get very large, yes or no? Yes. So if it starts to obstruct their airway so much, could it wake them up at night to catch their breath? Yes, good. So if they wake up at night a lot to catch their breath, would they be sleepy during the day? Because their sleep is interrupted. So yes, this is what we call sleep apnea. Tamam. If their adenoid, their tonsils, grow so big that it causes sleep apnea in these children, which is characterized as waking up at night, gasping for air, getting air, or trying to get air, plus daytime sleepiness, plus other things such as hypertension if it's an adult. And in children also, there's something called enuresis, which they urinate themselves because of, don't worry about that too much, but anyways, these findings indicate sleep apnea in children. And they have ADHD and anxiety and stuff because of their sympathetic hyperactivity. Because when they can't breathe too much, everything starts to get activated. Okay. They start to look for air. Okay. So that's why they have sympathetic hyperactivity and so on. Anyways, FYI. What you need to remember is if they have sleep apnea in children, the management absolute indication is tonsillectomy. Absolute indication. You must do it. Tamam. Another cause or another absolute indication is if you're suspecting malignancy cancer and you need to take biopsy, take biopsy by removing the tonsils. These are the two absolute. Then you have other things, such as if they have a complication of the tonsillitis, which is peritonsillar abscess, repeated infections, you might do it. Tamam? Now, next thing is what's the immediate complications? Here, what's very important is it's hypervascularized. The face is hypervascularized. Oral cavity is hypervascularized. So immediately you might have hemorrhage, immediate. Or you might have bleeding that occurs 7 to 10 days after the procedure. Why? Is in these patients who usually will undergo adenoid procedure or a tonsillectomy, they usually do it because of the absolute indication, which is sleep apnea. Sleep apnea patients, how do they breathe usually? They open their mouth just to increase the amount of air. So their mouth breathing. When you mouth breathe, this causes dryness in the oral cavity. So dryness plus scar equals opening scar, bleed. That's all I need to remember. I need to remember absolute indications. I really need to remember two for a tonsillectomy. Number one is sleep apnea. Number two is if you're suspecting malignancy and you want to take biopsy. Complication, bleeding, whether it's immediate or later. Tamam. Also, there's other complications that you don't need to remember and usually won't be asked. That's basically that. Now we go into the complications of a tonsillitis or pharyngitis, which is number one is this. Now, the tonsillar inflammation infection can spread to behind the tonsils and causes airway compression. So these patients will be very sick, very feverish, will be gasping for air. We have something called a stridor, okay? And what a stridor is basically is an abnormal extra noise when they're breathing. They're like it's gasping for air. This is what a stridor is. And usually it's upper airway obstruction, so it's something called inspiratory stridor. What does that mean? Is when they're breathing in air, you'll hear an abnormal noise. Also, these patients will be drooling, high fever because of obstruction. This is peritonsillar abscess, or another name for it is quinsy. Okay. I doubt you'll be asked this, but here's it in case you get asked it. Okay. This you will be asked. This patient has a very large submandibular mass, drooling, very bad breath, very sick, very feverish. What is this?
Ludwig angina.
Ludwig's angina. Perfect. What's important about Ludwig's angina is you need to, you can tell that's going to cause, this is the mass at the submandibular region. It's compressing. It's going to start to close this thing right here, which is the airway, slowly, slowly. So what do you need to do? Secure the airway. Intubate. This is very important. Intubate and then call ENT and call them to take them to surgery and antibiotics. Done. This is Ludwig's angina. The common cause of this is dental infection. This is Ludwig's angina. Now we go to this thing right here, which is a patient, a child, unvaccinated, coming to you with conjunctivitis, runny nose, and a cough, and the spots on oral cavity. Measles, good. What are these spots called? Koplik spot or salt and pepper appearance thingy, whatever. Anyways, this is Koplik spots indicative of measles. Measles, they cause the rash, and we talked about this in MSI. But before this rash, they have four symptoms, which are the four C's. Conjunctivitis, okay, Koplik spots, which is this, cough, and corina. Corina is runny nose, I think. Something like that, okay? But that's it. Okay, this is measles. It's a paramyxovirus, okay? Has a vaccine, and usually we don't see this anymore. Now, if you have a patient who bites a lot, they are night grinders, the teeth grinders, they can develop this overgrowth, which is a fibroma accident, which is the most common overgrowth or reactive overgrowth because of repetitive trauma in the area. Then we have this, which you'll see more and you'll learn more about in CVP, inshallah, which is a pyogenic granuloma. Good. Which demographic of patients do we see this in? Pregnancy. Excellent. And it grows in size in pregnancy. Perfect. And this is seen in here. Okay, you can see it's very vascularized tumor or overgrowth of blood vessels. Now we go to the larynx. Larynx has your vocal cords. Has true and false vocal cords. This glottic region is the true vocal cords. Above it is the vestibular folds, which are your false vocal cords. This is the glottic region. Above it is what we call supraglottic. Below it is infraglottic or subglottic region. Why is this important? If you have anything over here that's causing a mass, obstruction, paralysis, what will change? Your voice. Tamam? And you'll find it very, like you'll see it or see this change of voice fast. Tamam? This is important. If anywhere supraglottic or subglottic, it won't change their voice because it's away from the area. It might later on if it keeps growing. This is important for cancer. Tamam? Another thing, just like me, if you notice my voice is getting more raspy as the session goes. But this is because of my vocal cords hitting each other. That's how the phonation is repetitively. And this will cause raspy voice or hoarseness of voice. Okay. Now, one thing anatomically that I want you to remember is what nerve supplies all the muscles except the cricothyroid muscle. What nerve supplies it? Recurrent laryngeal. Excellent. What procedure commonly injures recurrent laryngeal?
Thyroidectomy.
Excellent. Thyroidectomy. Perfect. Good. So now you have a singer, you have a teacher coming to you, an aortic arch aneurysm because it goes beyond. Yes. This patient over here is a teacher or something complaining to you of hoarseness of voice that happens when they teach a lot. These are reactive nodules or Singer nodules, sorry. Singer's nodules. How do you know these are reactive nodules? Firstly, is bilateral, along the margin of the vocal cords. And this is for your information, what I'm about to say, but it makes sense more, is we divide the vocal cords into two segments, anterior 1/3 and posterior 2/3. For phonation, it's the anterior 1/3, the main function. The rest of it is for the airway protection, breathing. Tamam. So repetitive overuse will cause the way that you make sound is these two folds or the vocal cords will hit each other and will cause vibrations. Tamam. That's how you produce your voice. If they repetitively join together, this is going to cause reactive nodules. How do you treat this? Rest. Rest. Simply rest. Tamam. That's that. Now we come over here. You have this over here is 1 second, let me charge my. What is this diagnosis over here?
Polyp.
Polyp. Good. Now, polyp, how do you know this is a polyp? In histology, what is the histology of this?
Vascular root.
Fibrovascular core, excellent, with finger-like projections. This is a papilloma, excellent. Which virus causes papilloma? from the name?
HPV.
HPV, excellent, good. This is papilloma. Usually it has a stalk. So how do we tell the difference between a nodule and a mass and a papilloma? Is we tell the patient or we blow air. Tom, if it's a papilloma, usually it has a stalk, like here. You can see the stalk over here. So the mass will move. This is a papilloma. And we remove it surgically. Done. Now we go to here. What is this?
Malignancy, for sure.
Malignancy, good. This is laryngeal squamous cell carcinoma. The risk factor, number one, smoking. With it, it's very important, is HPV related. Tamam. Now, where is the most common location for laryngeal and alcohol? Good. Smoking, alcohol, HPV. And it's HPV 16, 18, and 31. Which location of the larynx is most common? Glottis. Next is supra, next is sub. Glottis, does it have a better prognosis or worse prognosis?
Better.
Why would it be better?
Because it's catched early, because of the voice.
Mumtaz, good. Detected early and has poor lymphatic drainage. تمام. Supra or subglottic, more lymphatic drainage, does not affect voice, later detected. تمام. That's it. Now, you have a Asian male presenting to you with epistaxis and you see on imaging a mass in the nasopharynx. Nasopharyngeal carcinoma. What virus causes it? EBV. Done. تمام. Keywords to remember for nasopharyngeal carcinoma. Asian male. These are the demographic features that you need to remember. Okay? And it's ABV related. And you can, or African children, usually it's described in an Asian male. Here is nasopharyngeal. For African children, it is EBV associated, and it usually causes, you'll learn this more detail, but lymphomas. Okay? This is lymphoepithelioma. Now we go into showing more detailed radiology just for the sake of completion. Some of these things, I have no idea why you're taking it now, and still, it's advanced for you guys, but anyways. Now we have here an X-ray, here a CT. تمام. This is a lateral view. تمام. So you can see here, this is the oral cavity, nasopharynx, soft palate. You can see somewhat over here, actually not at all, but you will see in children is adenoid over here, very small. Then this is the normal epiglottis. It's like a small little slit. That's it. تمام. This is important. And then you can see the clear airway over here. This is the glottis, supraglottic region. Sorry, here is a glottis, supraglottic, infraglottic. تمام. What else is important is this is the trachea, patent, everything is normal. Why am I telling you this? Is we want to look at a couple of things. Firstly, is if you see swollen adenoids, this is adenoid hypertrophy, this is usually in children. Number two is if you see a swollen epiglottis. This is what we call epiglottitis. And we'll see a picture of this. These are the two key things. Another thing is on X-ray, you might see a foreign body. تمام. These are the important things. Now, you have a child who's presenting to you with difficulty breathing, stridor, and a barking cough. They're sick, they have a fever, they're coughing. And you do imaging and you see this sign over here. Again, you shouldn't be taking this, it's a bit out of place in your block. But this is something called CRU, okay? Or laryngeotracheobronchitis, okay? This is basically an infection caused by parainfluenza virus in children, very common in children, that causes this inflammation in the larynx, the trachea, and the bronchi, that causes this X-ray finding that I want you guys to know in case they bring it to you in radiology is steeple sign. تمام. This is X-ray. Here you can see that there's a lot of edema in the airway. That's all I want you to remember. Okay. crew. This over here, you can see swollen adenoids. So what do we say here? In children, adenoid hypertrophy. Adenoids are very huge. Here it is again. Adenoids are very huge. If we go back to the normal, can you even see them? No. Here, big. تمام. Swollen adenoids. Here you have a patient with who has drooling, who has difficulty breathing, high fever, and you can see on X-ray the epiglottis is now huge. This is what we call epiglottitis, and it's caused by Haemophilus influenza. تمام. Again, for the sake of identification, the crew was a steeple sign on X-ray. Here, this is what we call a thumbprint appearance. Look at my thumb. It looks like the epiglottis right now. Okay, that's basically epiglottitis. Another thing is this. This is foreign body aspiration. I want you to remember one thing, important thing, is we do two images. X-ray anterior posterior and X-ray lateral view. We need both to diagnose patients with foreign body aspiration. One is not enough. Why is that so? Here we can see there's a foreign body. Here we can see where the foreign body is. In this case, is it the esophagus or the trachea? It's esophagus. Okay, this is the trachea. You can see the air. Okay, air is black. Here is esophagus, which is posterior. So, and that's it for oral cavity and the throat. Is everything clear?
Yes.
So now we go into the last part of this section, which is the ear. The ear, the details of the ear in terms of the physiology, detailed anatomy, I will not cover it here. Rafa, I think, made a past session covering it in case you want to go into details of it. But I'll explain very important features that will relate to clinical. Now, the ear, we will separate into three. صح? We have the external, the middle, and the internal ear. تمام? What is the function of the external ear?
Collect sounds.
Excellent. Collect all the sounds, funnel it into the external acoustic meatus or the external ear canal. تمام? It goes and then hits the tympanic membrane. This will cause vibrations to occur on the middle ear, which through which structures the ossicles. So you have three ossicles. You have the malleus, incus, stapes. Stapes will hit the oval window. This vibration, mechanical vibration, will turn into fluid vibration. This fluid vibration will cause changes, and this changes will open channels, potassium, whatnot, hearing. The hearing transmissions will travel through the cochlear nerve. This is the ear in a nutshell. تمام? What's important clinically is if you have anything that's obstructing the hearing from the middle ear and the external ear, this is what we call conductive hearing loss. تمام? If it's affecting the cochlea or the nerve, this is what we call sensory neural hearing loss. تمام? So why do we call it conductive? Is the main function of the external and middle ear. First, external collects all the sounds, conducts it to the middle ear, conducts it to the internal ear. So if you have anything affecting the conduction system of the ear, which are these two, this is conductive hearing loss. If it affects the cochlea or the nerve, sensory neural. So if you think about it, anything obstructing here, affecting here, fluid buildup here, this gets ruptured, ossicles are hard and they attach to each other, they cannot move properly. You have a blockage of the suction tube, conductive hearing loss. If you have, for example, the hair cells damaged, sensory neural. If you have, for example, the endolymph is too much, hearing loss. If you have, for example, nerve cut, hearing loss. Internal acoustic meatus tumor, hearing loss, sensory neural. This is how we tell the difference between the two. But how specifically, I'll explain later. Now, when we're examining a patient, let's just say hearing loss, we look at the external ear to look for any pathologies of the external ear. Then we go deeper. Here is the tympanic membrane. What is this structure over here?
Malleus.
Malleus, more specifically, the part of the malleus that's attaching to the tympanic membrane is called the umbo. Okay. Then this is the handle of the malleus. Okay, this bone. Okay. Over here is something that we call is the cone of light. So this, because of the cone of light and the handle of the malleus, I can tell that this is the anterior border of the tympanic membrane. It's usually anterior, inferior, the cone of light, but it's not something that we go off. We go off of this, which is the malleus, handle of the malleus. It's anterior. So this is posterior. This part of the tympanic membrane is what we call the pars flaccida. Here is the pars tensa. Okay. Tamam. Now, what's important as well is in your slides, it says that this portion over here is where we put the tympanostomy or laryngotomy tube. So just go with that. Okay. What's important as well is there are certain nerves that supplies here, such as the auriculotemporal, trigeminal, and vagus. What's important about the vagus in this part of the tympanic membrane is if you stimulate it in an adult or a child, elderly or a child, this can cause syncope. So when you're looking at the middle ear or looking at the tympanic membrane and you, for example, touch, or for example, you put the Q-tips inside the ear and they get syncope, this is why, because of the vagus nerve. Another thing is there's an important nerve lying over here. What's this nerve over here? Chorda tympani. Excellent. Good. Mumtaz. Chorda tympani. Why is this important? As I said, anything affecting the ear could cause facial nerve paralysis. So here in this case, it can affect the taste. Tamam? Good. Now we go into details of the middle ear. Another thing I want you to remember, before I move on, is when we're commenting on any pathologies of the tympanic membrane, we comment on a couple of things. Firstly, the color of this. This should be clear. Okay. If it's red, this is a sign. If there's a lot of, and the cone of light, excellent. If you see the cone of light, this is a good thing. Then we look at the ossicles. Can we see too many ossicles or this is normal? This is normal. If you see too many, this is retracted tympanic membrane. If you don't see any markers over here, such as any of the, you can't see the handle of the malleus, this is a protruding tympanic membrane. Another thing is if you see exudates, okay, swelling, white fluid coming out of there. Another thing is perforation. If you have, for example, a suction tube blockage that accumulates a lot of fluid in the middle ear, this will cause so much pressure buildup to the point where it will perforate to allow the pressure to relieve. Okay, so you'll see perforation. These are the things that we'll see on tympanic membrane for pathologies, and we'll go through it one by one in the next slides, inshallah. Then we go into the middle ear. Middle ear, what I want to remember are the borders. Why is because you need to understand the complications of the pathologies of the middle ear. And it relates to the borders and the structures inside the middle ear. So, if we're looking at the middle ear, the medial border is the cochlea. Lateral is the tympanic membrane. Superiorly is the tegmen tympani, which separates it from the middle cranial fossa. Inferiorly, right below it, is the jugular. Okay, so the jugular vein. Then we have anterior and posterior. Anteriorly, which is this border, you'll have the carotid. Posteriorly is you have the mastoid. Tamam. Why is this important? Firstly, if you have a fusion in the middle ear, the pressure in the middle ear will go up. Okay. Where is the air gonna escape to? Lateral. What will it do? Perforate the tympanic membrane. That's number one. So tympanic membrane perforation. What will this cause? Hearing loss. That's number one. Number two is if you have infection of the middle ear, where will it go to? Two easy areas, up or posterior. Why posterior? You can see it opens to the mastoid, the cells, the air cells in the mastoid. So what will it cause? Mastoiditis. If it moves up, what will it cause? Brain abscess. But just by knowing the anatomy, you know the complications of the diseases. Okay. Another thing that's important is you can see this, the facial canal. Okay, so if you do any surgeries here, you might damage the facial nerve. This is why you need to learn the middle ear anatomy in detail. Now, another thing is the bones, the ossicles, you have malleus, incus, stapes. Okay, very easy. Okay, in terms of the anatomy of it. Now we go into the inner ear. So the inner ear, once you have hitting of the oval window from the stapes, you will have mechanical turns into fluid vibrations. The fluid will go from the base of the cochlea to the apex of the cochlea and go back to hit the round window. Tamam? This will cause vibrations that will move the organ of Corti and whatnot, hair cells over here, potassium high over here, whatnot, physiology. So, what's important is the hair cells that are located in the base of the cochlea. Does it receive high frequency or low frequency? I need you guys to know this. High. Base, which is over here, high. Here's the apex. It's low frequency. Tamam? Why is this important? Is number one is when sounds go to the inner ear, which part will be affected first? High or low? Base or apex?
Base first.
Base first, because it's the first thing. Okay. Why is this important? Is two things. Barotrauma, which means, for example, someone goes to a concert or whatnot, or for example, they're right next to an air jet and they have hearing loss right after it, is because of damage to the hair cells here in the base, high frequency. Or age-related hearing loss is they lose high frequency first because of the hair cells here. Tamam? This is why you need to know this. The other thing is the fluid that's located inside the scala media is endolymph, which is high in potassium. If you have accumulation of endolymph over here, it will cause hearing loss. Tamam? That's basically that in terms of anatomy and physiology. Okay, now we go into clinical details, which is important. Now, as I told you, you have two types of hearing loss, sensory neural or conductive hearing loss. Okay, what will the patient complain to you? Simple, I cannot hear. It's your job to know whether it's conductive, which is anything obstructing the air, either in the external ear or any pathologies of the middle ear, versus sensory neural. Do they have a cochlear defect of the hair cells or do they have a nerve defect? It's your job to know the difference and to understand the difference. How do you do this? Firstly, is clinical testing. Obviously, other than history, which will tell you everything. But clinical testing is Weber and Rene. We use a tuning fork. The frequency of this tuning fork is 512 hertz because it's closest to the normal ear. So this is just common knowledge that you should know, especially pro for examination. 512 hertz. So what do you do? The first thing you do is Rene test. Okay. So what does Rene test do? It checks whether or not you have air conduction more than bone conduction or vice versa. How? Normally speaking, where do we receive sounds from? From air. It goes to the external ear to the middle ear. This is normal. So where would you suspect to hear more from air or bone? Normally.
Air.
Air, because that's how we usually hear asla. We don't usually hear from bone. So in a patient, we put the tuning fork in front of the ear. And you ask the patient, can you hear? Yes or no. Then we go to bone. This is to explain it. In reality, to what we do is we put it at the mastoid. Okay? And we ask the patient, can you hear it? Can you hear it? Can you hear it? Tell me when you don't hear it. When they don't hear it, we switch to the air. على طول. If they can continue hearing it, that means that the air is louder than the bone. Or simply, you go in front of the air, in front of the ear, you check for air conduction. Can you hear this? Yes. You go to the bone, to the mastoid process. Can you hear this? Yes. Which one is louder? Air. This is normal. Air conduction will be more than bone conduction. Tamam? Now, if you have blockage of the external ear, or you have otitis media causing disruption of the tympanic membrane, bulging of the tympanic membrane, anything causing conductive hearing loss. Would you be able to hear from the air? No. So what would be louder, bone or air? Bone. Why? Is the bone will transmit these vibrations from the tuning fork straight to the cochlea. It will skip everything else. So you'll hear bone more than air in conductive hearing loss. Okay? This test, Renee, will tell you conductive or not. It will just tell you whether or not this patient has conductive hearing loss. Tamam. If they have air more than bone, it's either normal or sensorineural. Obviously weak. And if you compare both sides, if they have this ear, they can't hear, but this ear, that's fine. You do both sides, this ear, they'll hear good noise, hear weakened. But air more than bone for sensorineural. Tamam. Is concept of Renee test clear? Okay.
Yes.
Tamam. Next thing is Weber. We put the tuning fork on the vertex of the skull, and then we check for lateralization, okay, or localization. Normally, both of your cochlea should be normal, صح? So the vibrations will spread straight to the cochlea, both sides equally. So in normal patients, it should not localize. You'll hear it both equally, both sides, or you'll hear it down the middle, normal. If you have conductive hearing loss, you need to think about it. Bone conduction will skip everything and go straight to the cochlea, صح? So what will happen is if you put it down here in the middle, will it go to the ear with conductive hearing loss or will it go more to the normal here? Affected or normal?
Normal.
Relax. Affected. Why? In conductive hearing loss, you don't hear anything from outside, but your cochlea is normal. In the normal ear, you hear everything outside, so background noise and everything. And then when you put the bone conduction, this cochlea, which is the affected ear, let's say this ear is affected, can't hear anything from to my left, cannot hear anything. So the bone conduction, the vibration will go straight to the cochlea to the left side, ignoring all background noise. This ear will get the vibrations from the bone conduction and all the background noise. This is the good ear. So what ear will hear it more? The affected ear, in conductive. And sensorineural, this whole cochlea is gone. So it will go to the good ear. Now, is this clear? Tamam.
Yes, thank you.
Okay. This is Renee Weber. Renee will tell you whether bone is more than air or air more than bone. So it will tell you whether or not this patient has conductive or sensory conductive or not. If it's not conductive, then it's most likely sensorineural, but it won't confirm it for you. Weber will localize it. It will strengthen your suspicion. Right? You obviously need to go to more objective tests. Tamam? Then we have other audiological evaluation tests. Tympanometry would look at the compliance of the tympanic membrane, not too much importance here. Autoacoustic emission, all I want you to remember is one thing, it's indication. It's to look at newborn babies with hearing loss and it evaluates hair cells. This statement that I just said, that's all you need to know. Autoacoustic emission is for babies with hearing loss and you want to evaluate the cause of the hearing loss. Tympanography is important and you will get tested on this. Okay? This has been tested before, yani. Tympanography is to check the compliance of the tympanic membrane. Okay? Now, how does this thing work? A over here is the normal. Tamam? Now, the pressure of the middle ear should be normalized. Why? Is because you have this suction tube. It should be open. Tamam? Another thing is you have the ossicles that will keep it in place. Now, if the pressure is normal, this means that the eustachian tube is normal. There's normal pressure inside the middle ear. Tamam? AS and AD. What are these pathologies? Here, the compliance in AD is high. What does this mean? Is that the ossicles are no longer attached to the tympanic membrane. This is what we call ossicular discontinuity. Tamam? Why? is there's so much more compliance here. That means that the tympanic membrane is moving so much. Why is that so? Is that these ossicles are not attaching properly to each other. This is what we call a ossicular discontinuity. The ossicles will keep the tympanic membrane, especially the malleus, the umbo. It attaches to the tympanic membrane. If there's discontinuity, it will move like this. If it's not moving that much, this means that the ossicles are stiff. But the pressure is normal. That's crucial. Then we have over here. Here is if you have, for example, a protracted tympanic membrane. Here, if you have a ruptured tympanic membrane, the compliance is all-time low and the pressure is weak because there's a rupture or there's a fusion. Are these tests clear and is this one clear?
Could you please wrap it very quickly?
For this test again?
Yes, please.
Tamam. Tympanometry, don't worry too much. I doubt it'll come, but it's the same concept as this. It's just to check the compliance of the middle ear and check the pressure of the middle ear. Autoacoustic emission is to check for babies with hearing loss, and it checks the hair cell function. If they pass the test, they don't have sensorineural hearing loss. Tympanography is to check the compliance of the tympanic membrane. Usually the pressure is 0 because of the station 2. Now, if the pressure is normal, but there is more compliance, this is ossicular discontinuity. If there's normal pressure but low compliance, this is ossicular stiffness. If there is low pressure, negative pressure with semi-normal compliance, this means that there's just a fusion inside or the tympanic membrane is protruding outwards. If it's B, that means the tympanic membrane has ruptured. Is this good?
Yes, thank you so much.
No problem. Then we have auditory brainstem simulation or ABR. Again, it's a check for the nerve function. Don't need to know too much about this. This is the most I yield. Audiogram. You need to know how to interpret the audiogram. So now, we have two important hearing parameters. We have the decibels, which is how loud you hear, and then you have this is the decibels, which is the hearing level, and then you have the frequency. Tamam? So now, in this case over here, what you need to remember is the normal ranges. If we look at hearing above 20 decibels, below 20 decibels, okay, is normal hearing. Anything below that is affected. Okay, you do not need to know this in detail. I do not think this will come, but just for you to know, 20 to 40 is mild hearing loss, 40 to 55 is moderate, 55 to 70 is moderately severe, 70 to 90 is severe, and below 90 is profound hearing loss. Now, we look at air versus bone conduction through this audiogram, and it will give you more objective analysis. Okay, so now, here in this case, we have different symbols that will represent whether or not it's a right ear or left ear versus bone, air or bone. In this case over here, air conduction is a circle and bone conduction is this arrow, and it's in the right ear. So in this case, they're both very similar, which is normal. Tamam? It's fine. This is normal. And it's above it's below 20 decibels. So this case, this is normal hearing, صح? Normal frequencies. Okay? And then we'll apply it inshallah. Something that we do is something called masking, which I want you to remember just the concept of, is basically in children, just to prevent bias, is we cover the good ear just to remove, or not cover, is basically we play a lot of noise in the good ear just to isolate the bad ear. Okay, this is what masking is. Now we go into details of this. Let's just say this is air conduction and this is bone conduction. Bone will be more than air. What is this? Conductive or sensorineural? Conductive. Tamam. Bone will be more than air in conductive hearing loss. This is important. The difference between them is 30 decibels. More than 30. But don't worry about that. And if there's separation between bone and air, this is conductive hearing loss. Tamam. This is what you see classically with audiograms with conductive hearing loss. Now, what is the most common cause of conductive hearing loss in adults? We all have it.
Wax.
Wax. Good. Wax impaction. In children, it's otitis media. Now, you have this patient who comes to you with severe ear pain, abnormal discharge, and you take further history, they tell you, oh, we were swimming.
Otitis media. So swimmer ear.
Not media. Oh, external. Okay. External. With swimmer's ear is usually otitis externa, and I'll tell you the organism, inshallah, next slide. But basically, it's inflammation or infection of the external ear, which involves the pinna, the auricle, all these, and then the external canal. So in this case, you see a lot of this pus in the ear canal that's narrowing the ear canal. This would cause conductive hearing loss. Tamam? So this is usually caused by increased humidity in the external ear, in the ear canal. This could be because of swimming. This could be because of wearing hearing aids. This could be because of earplugs. This could be whatever, ear trauma from outside. There's two organisms I want to remember. If it's swimming, Pseudomonas, usually the most common one, Pseudomonas. Diabetic patient, immunocompromised, Pseudomonas. If it's just because of irritation or they're wearing hearing aids or whatever, it's Staph aureus. Okay, or trauma, because it's in the skin. In this case, it's acute, this is acute otitis externa. You can see all this pus outside. This is more chronic. It's starting to be fibrosed. This is very life-threatening. It's seen in diabetic patients, in immunocompromised patients, and it's basically characterized as granulation tissue on the base of the external canal, and it spreads into the skull base and the mastoid. This is necrotizing malignant. In this case of otitis externa, it's black spots in the external ear. This is usually fungal cause. In this case, you have vesicles that form. This is herpes or viral cause. What I want you to remember specifically is number one, acute is caused by Pseudomonas and Staph aureus. Don't worry about chronic too much. Necrotizing malignant, it's seen in diabetic, immunocompromised patient, caused by Pseudomonas, life-threatening, and the key word is granulation tissue. Okay? Fungal is Asperger's. Don't worry too much. Any viral HSV. Simple. How do we treat these? Acute or antibiotic. Okay? To cover what? Pseudomonas. So ciprofloxacin, fluoroquinolone. Chronic, there's usually an underlying disease causing it, such as eczema or whatever. So you treat the underlying disease plus give antibiotics. In necrotizing malignant, IV antibiotics, which is IV ciprofloxacin. Fungal, you treat the fungal infection or antifungals or topical antifungals. This one also you give topical too. And then this one viral antivirals. Otitis externa, is this clear?
Yes.
What's this organism?
Staph aureus.
Excellent. This is a gram-positive cocci in clusters. It's beta hemolytic, it's coagulase positive, catalase positive organism. Staph aureus. Then we go into here, which is this one. What is this?
Pseudomonas.
Pseudomonas, good. Gram-negative rods, dye pigment producing, which is pyogranin, pyoverdin, and whatnot. And it's oxidase positive. Pseudomonas. Then now we go into this, which is a kid who had tonsillitis, later on developed ear pain, otalgia, okay, ear discharge. And you look at tympanic membrane, it's bulging, erythematous, red, and there's suppuration, which is pus behind the middle ear. What is this? Or behind tympanic membrane? This is otitis media. Otitis media, it's the most common cause of conducting hearing loss in children. Okay. It's usually one of the most common cause of laryngotomy tube placement, tympanostomy tube placement in the middle ear for children. And it's one of the most common cause of giving antibiotics for children, otitis media. Okay. Now, the pathogenesis of otitis media is usually due to closure of the suction tube, because in children it's much shorter. So a closure of the suction tube will cause secretions to accumulate in the middle ear, which will cause bacterial overgrowth. And this causes slowly buildup of pressure in the middle ear plus pus formation. So you'll see a protracted or bulging tympanic membrane that's very red, and you can see some pus behind it. Can you identify any of the normal structure of the tympanic membrane? Like, can you see you can see a bit of the cone of light, but it's displaced. But can you see the malleus? Can you see the umbo? No, because this is a protruding tympanic membrane. This is acute otitis media. You have 3 infectious organisms. What's the most common cause? Number 1 is strep pneumo. Number 2 is Haemophilus. Number 3 is Moraxella catarrhalis. You need to remember this in detail. What are risk factor? Immunocompromised baby, let's just say smoking parents. Yeah, could be SAQ. Smoking parents, so smoking in general, breastfeeding, or not breastfeeding, bottle feeding, more specifically, and
And
non-vaccinated.
nursery, I think, right?
Nursery, yes. Yeah. So now we go through them one by one. Is this one gram-positive cocci in chains, and it's optogen sensitive, and it's alpha hemolytic. Strep pneumo, good, perfect. This one, gram-negative coccobacilli, Haemophilus influenza. Which one would cause otitis media? Typable or non-typable?
Non-type.
Excellent, non-typable, good. Now, Haemophilus needs 2 factors. Factor 10, factor 5. Factor 10 is hemin, factor 5 is NAD. Which organism did we put with Haemophilus here to cause this effect? It has NAD. In this blood agar, we put Staph aureus, which has NAD, which will allow it to grow. Tamam, allow the Haemophilus to grow. This is just chocolate agar. Tamam, I think that's all I want to say for this. Now this, it's a gram-negative diplococci, Moraxella. Is it DNase positive or negative? I'll tell you. It's oxidase positive, DNase positive, and what other? Catalase positive. Okay, good. And that differentiates it from Neisseria. Okay, that's Moraxella. Now we have this. We have a bulging tympanic membrane with no erythema. It's not red. It's a normal color, but you see bulging points. So this tells you there's a fusion. This is what we call otitis media with effusion. Okay. This is otitis media with effusion. Okay. This, how do we treat it? Tympanostomy tube. Okay. Otitis media with effusion. There's a fusion behind the tympanic membrane. As you can see, there's air pockets. Tamam. With no erythema of the tympanic membrane. Okay. There's no redness. This is otitis media with effusion. What is this? Complication of otitis media.
Perforated.
Perforation or chronic suppurative, basically perforated. You can see everything in the middle ear. Okay. This is a smaller perforation, and it's mostly seen in acute otitis media. Then we can see here just some tympanosclerosis, which is calcification and hardening of the tympanic membrane because of the infection. Now, what is this over here? It's retraction of the eardrum. Basically, the only ossicle you can see is the malleus. Here you can see the head of the stapes. You can see the stapedial tendon, the round window. There's going to be also a bulge of the cochlea, which is over here. and you can see a tympanostomy tube. This is retraction of the eardrum. Okay. Now you need to treat otitis media very well, and it's easy treatment. It's oral amoxicillin. If the patient is allergic, use macrolides. Simple. You need to treat it before complications occur. What is this complication?
Brain abscess.
Excellent. Brain abscess. Good. Why? How can brain abscess occur? Direct spread, superficial. تمام. Tegment tympani. Good. Now, this cause of conductive hearing loss, usually due to, no, not close, usually due to repeated infections, and it's characterized as granulation tissue that's, or not granulation tissue, keratinized tissue, skin, that's located at the apex of the tympanic membrane, or not tympanic membrane, but of the apex uh, of the ear canal. Keyword is keratinized skin in an abnormal location, which is the middle ear. This is cholesteatoma. This is high yield. Okay. Cholesteatoma is keratinized skin, okay, in the wrong place. It's not cholesterol, it's skin. In the wrong place. What is the wrong place? Middle ear, which will cause conductive hearing loss. And it's usually because of otitis media infection. Okay. This is cholesteatoma. This is high yield, and you will most likely get this for a cause of conductive hearing loss. And you need to somewhat list, basically how I made this session, or this part is I said the conductive audiogram, and then now I'm mentioning all the causes of conductive hearing loss. Then we'll go to sensorineural, then we'll go to, we'll wrap it up at the end. This is one of the common cause of conductive hearing loss. تمام. This one is less important to remember, but this is called an osteoma, bone tumor, and we took this in MSI. But it's basically, you can see this bone growth, and that's blocking the ear canal, osteoma. Here, it's simple, is you have atresia of the ear canal, and we basically put implants, and we did plastic surgery and replaced, did a reconstruction. Simple. Simple cause of conductive hearing loss in terms of that, it makes sense. Okay, you have a complete loss of the external ear. That's it for conductive. Okay, now what is this? This rectangle or this square is bone. Is air. This is bone. Both are below 20. If they're both, yes, if both of them are below 20, this is sensorineural. تمام. Both are below 20. Okay, air and bone are the same. So if it's sensorineural hearing loss, where is the defect? Cochlea or the nerve. Good. تمام. Now we go to the causes. Okay, one thing is aging related. Aging related is called presbycusis. Okay, this is aging related. Okay, then we have barotrauma, we have neurologic, such as acoustic neuroma, which happens in the internal acoustic meatus, which disrupts the nerve itself. Then we have autotoxicity. Okay, so any drugs that can cause it, infectious, autoimmune, and so on. Now, hearing worsens in noisy environments. To make sense of this, is noisy environments are higher frequency. Where is the hair cells for higher frequency located? At the base. What gets damaged first because of repetitive noise or aging or traumatic? The base. Okay, so in this case, it will affect higher frequency more, which is in noisy environments. Then we have this cause. I want to talk about more detail when I talk about vertigo in the next slides. Okay, this is sensorineural. You also have congenital causes, which is usually autosomal recessive, and that's all I want to remember. Okay, Down syndrome can cause it, such as another congenital or hereditary disease called Alport syndrome. There's a lot of things you don't need to know in detail for this, okay? Just know if it's congenital, it's autosomal recessive. One of the more common causes is aging, which is presbycusis. Then we have neurologic acoustic neuroma. If you have facial nerve palsy plus the hearing loss, then you suspect neurologic. And then if they're taking any medication, then develop sensorineural hair loss. This is clear, okay? Now, what is this? Both bone and air is below 20, but bone is more than air. What do we call this?
Sensorineural.
No. If they're both the same, it's sensorineural. Okay, in conductive, you suspect bone to be normal. Should be up here, but they're both abnormal. If it's conductive, bone should be here, air should be here. But here, both bone and air are abnormal. Okay,
So both.
exactly. Mixed hearing loss, both. You don't need to go into detail with this, just memorize the audiogram, okay? To recap the audiograms, because you will get a question on this, okay? Let's just say this X is air, and this arrow is bone. In this case, they're both together above 20. Is this normal or abnormal?
Normal.
Normal. If bone is up here, air is down here.
Sensorineural.
Lex,
Conductive.
conductive. Bone is normal. Air is abnormal. If you have both the same and it's below 20.
Mixed.
No, both the same. Sensorineural. Okay, I'll mention it again. Then if you have bone more than air, but both below 20, which is normal decibels, it's mixed. Again, this is air, this is bone. Both of them are above 20. There's no space between them. This is normal. Bone is above 20 or below 20 if you want to call it 20 decibels, above this line. Good, خلاص. This is bone, okay? This is air. Bone is better than air. Bone is normal. This is conductive. Bone being normal tells you that the cochlea is normal. Okay, so conductive hearing loss. Both bone and air are below 20, below this line, and both are the same. Both are equally affected. Sensorineural. If bone plus air are below 20, but there's a gap between them, telling you that bone is better than air, it's mixed, but they're both defected. Does this audiogram stuff make sense?
Yes.
Tamam. This will come in the exam, most likely. Now, for treatment of hearing loss, all I want you to remember is that we treat the underlying cause, that's number one. And for conductive is we just take out whatever causing the conductive hearing loss and to solve the issue. For sensorineural, it depends on the cause as well. You need to treat the cause. Now we go step by step. And all I want you to remember is if for the sensorineural method, if we cannot treat the cause and we need to, for example, presbycusis, we give hearing aids first. If it didn't work, then we do cochlear implant. It will bypass, we'll basically put it here, for example, and it will bypass everything and go to the nerve itself. That's it. Okay. Don't go into detail with this. Don't worry about what I just said, but we just have different modalities to treat hearing loss. The most important thing, firstly, is you treat the underlying cause of the hearing loss. Then we can look into if it worked or not. Last concept of this crash course is the vestibular apparatus for the balance. We have different organs in the inner ear. We have the utricle, saccule, and the semicircular canals. Utricle is when you move the head side to side. Sacral is for vertical movement, and rotatory movement is for semicircular canals. Inside of these organs, the utricle, sacral, and the semicircular canals are these otoconia. What's the pathology in this case is vertigo. Okay, vertigo is a sensation of spinning or swaying of oneself or of one's surroundings. As children, we all used to spin in a circle, get dizzy, and then fix. This is vertigo. There's a sensation of spinning. When we stop, that's vertigo. What's important for you guys is you need to differentiate what's central and what's peripheral. تمام? Peripheral vertigo is anything affecting the inner ear. Anything else is the central vertigo. What else will control balance is the brainstem, the vestibulocochlear nerve there, and the cerebellar. Okay? So, for central causes, stroke, multiple sclerosis, migraine. You know them in detail from neuro. We don't have to talk about them. Peripheral is inner ear pathologies, and we have three important ones. BPPV, benign paroxysmal positional vertigo, Meniere's disease, and vestibular neuritis. Now, I want you to firstly know the difference between them, between central versus peripheral, on these physical examinations. Number one is, I want you to remember, is nystagmus. Nystagmus is the abnormal pupillary movement because of any movement. تمام? Now, nystagmus in peripheral vertigo is either horizontal, it's usually horizontal. In central, I want you to remember, it can be anything. And importantly, is vertical nystagmus. The eye looks like this. This is vertical nystagmus. If it's like this, it's horizontal, most likely peripheral vertigo. If it does not does the vertical nystagmus, it's not central. That's number one. Number two is that it's fatigable in peripheral, meaning is that after 1 minute, your muscles get fatigued and khalas. It will stop. Okay? Not the muscles, but the nystagmus itself. It's fatigable. It does not last usually more than 1 minute. Last thing is latency period. In this case, there's a time period where it waits to have another episode of a nystagmus. تمام. The next thing is the head impulse test or the vestibulo-ocular reflex. Basically, you tell the patient to fixate on one thing and you tilt the head. You'll see both eyes moving or keeping it symmetrical to look at the central point that you're trying to look at. If your eyes start to deviate while you're looking and you're moving the head, this is an abnormal head impulse test. Okay? It's normal in central. تمام. Abnormal in peripheral. Now, why is this important to tell the difference? Central is more severe, peripheral is less severe. Okay, that's it. Hearing loss, you suspect it in peripheral. Posture instability, more in central. Sense of motion, more decreased sense of motion in peripheral. Nausea and vomiting, more in peripheral, but it varies. You need to investigate this urgently. You need to just find what's causing the peripheral vertigo. The difference between them, are they clear? Okay.
Yes.
So now what you really need to know is the causes of peripheral vertigo. Okay. You have first one is vestibular. Let's go for the most common, which is this one, BPPV. BPPV is benign paroxysmal positional vertigo, and it's caused by something called otolithiasis. Okay, where the otolith inside the inner ear are dislodged. Okay, that's the cause. How does it present? Usually someone telling you that when I move, I get vertigo. And then you might also get nystagmus, which is horizontal. Okay, it's usually horizontal. Don't ignore this. Okay, and it usually resolves around 1 minute. This is BPVV. How do we diagnose it? It's with the Dix-Hallpike maneuver. We lay the patient down with the head a bit more lower than the rest of the body, and we rapidly move their head. Okay, when we do this, This will cause nystagmus. Okay, this is a positive Dix-Hallpike maneuver. How do we treat it? Is with the Epley maneuver. Epley will basically head repositioning any exercises. It will reposition the otolith to its normal position, and it solves the issue. تمام? This is it basically. Meniere's disease, I want you to remember a triad, which is hearing loss, unilateral, vertigo, and tinnitus, which is ringing in the ear. It's caused by endolymphatic hydrops. There's an endolymph, which is this. There's a lot of endolymph. It would cause atrophy of the organ of Corti. Meniere's disease. That's basically that. How do you diagnose it clinically? And you treat it by certain medications that you won't, I don't think you need to know. Then vestibular neuritis. Easy thing to remember about this is it's post-infectious. Patient had an infection, developed vestibular syndrome, which is the nystagmus, the hearing loss, even if there's labyrinthitis, and what's it called? The vertigo. Okay, and it's usually because of an upper respiratory tract infection, which is a key thing in the clinical case. Guys, this is high yield. Know these three, no, this might come as an SAQ. Okay, and we know this is Meniere, and I am done with this part of the crash course. Do you guys have any questions? الله يعافيك الله يجزاك خير. Inshallah, tomorrow, I'll be going over ophthalmology. Should cover all of the eye. The only thing I will not cover is details of eye anatomy, and specific details, even though I covered most of it. Physiology I will not cover, and embryology I will not cover. The rest is all covered.